You've surely seen it countless times, that spiralling red and white pole outside barbershops. It's so familiar you probably don't even notice it anymore. But that cheerful candy-striped cylinder harbours a secret, one that drips with blood, pain, and the peculiar history of medicine. Tonight we journey into the world of the medieval barber-surgeon, where the same hands that trimmed your beard might also amputate your leg, extract your teeth, or drain your blood into a wooden bowl. Before you settle into a comfortable position, take a moment to like this video and subscribe to the channel, but only if you truly enjoy the content I create here. And please let me know in the comments where you're watching from and what time it is in your part of the world. It's always fascinating to discover who's joining us from across the globe. Now, dim your lights, perhaps turn on a fan for that gentle background hum, and let's immerse ourselves in tonight's journey together. Imagine walking down a narrow, winding street in a 14th century town. The air is thick with the sense of life. Bread from the bayer, manure from passing horses, smoke from countless chimneys. Through this aromatic chaos cuts a particular smell, a strange mixture of herbs, blood, and something sharply medicinal. Your eyes follow your nose to a shop with a small crowd gathered outside. Above the door hangs a wooden sign swinging slightly in the breeze, and beside it that familiar pole, except it's not painted. Instead, actual bloodied bandages wrap around it, fluttering like grim flags announcing the barber-surgeon's trade. This is no modern salon with its pleasant shampoo smells and fashion magazines. This is a place where beauty and brutality blend together in a dance as old as human vanity and suffering. Inside, a man might be getting his weekly shave while another sits nearby, sleeve rolled up, blood trickling from his arm into a bowl. In the corner, someone might be gritting their teeth as an abscessed molar is wrenched from their jaw, all under the same roof, all by the same hands. The barber-surgeon stands at the centre of this theatre of grooming and medicine, scissors in one hand, perhaps a bloodletting blade in the other. His apron is stained with these evidence of his dual profession, hair clippings and bloodstains mingling in a patchwork of his daily labour. He's not a physician, those lofty university men who rarely touch patients and speak in Latin about humoral imbalances. No, the barber-surgeon is a man of practical skills, of hands-on knowledge passed down through generations of apprentices. His shop is a strange hybrid of salon and surgical theatre. Hanging on the walls are tools that might make your skin crawl, bone saws with teeth worn from use, pliers for pulling teeth, curved needles for stitching wounds. Beside them, more familiar implements, mirrors, combs, razors kept sharp enough to shave a face or open a vein with equal precision. Shelves hold jars of mysterious substances, herbal ointments, caustic powders, soothing balms, and styptic mixtures to stop bleeding. In medieval Europe, these men, and sometimes women, were the frontline healthcare providers for ordinary people. When you fell ill, yes, a physician might diagnose you, if you could afford one. But when something needed to be done, a growth removed, a tooth pulled, a wound stitched, or bad blood drained, you went to the barber-surgeon. They were the hands-on healers, the ones who literally dealt with the blood and gore of human ailment. Their story is one of remarkable duality. On one hand, they performed services that provided real relief, draining abscesses, setting bones, removing painful teeth. On the other, many of their treatments were based on medical theories we now know to be completely wrong, causing unnecessary suffering and sometimes hastening death, rather than preventing it. They were both healers and harmers, working with the best knowledge available to them, however flawed. Tonight we'll walk through this bloody fascinating history together. We'll explore how monks became the first barber-surgeons and why the church eventually forced them to give up the blade. We'll peek inside the medieval barber's shop and hear the sounds, smell the scents, and see the sights that would greet a customer from centuries past. We'll examine their tools, some terrifying, some ingenious, and learn how they were used on conscious, often screaming patients. We'll follow the barber-surgeon through his day as he moves from mundane haircuts to life-or-death surgeries, from trimming beards to treating battlefield wounds. We'll discover how these practitioners learned their craft, from boyhood apprenticeships to guild memberships, and we'll see how they navigated the complex social and professional hierarchies of medieval medicine, often looked down upon by physicians, despite being the ones who actually touched patients and performed procedures. You'll learn about bloodletting and why people believe that draining your vital fluids could actually make you healthier. You'll discover the crude dentistry of the era, making your next trip to the modern dentist seem like a luxury spa visit by comparison. You'll witness amputations performed with nothing but alcohol, and perhaps opium for pain relief, and the cauterizing irons heated red hot to seal spurting blood vessels. In this journey through history, you'll meet the forgotten women who practiced as barber-surgeons, often taking over their husbands' businesses after being widowed. You'll see how these practical healers responded when plague swept through towns, donning strange beaked masks filled with herbs thought to protect against miasmatic bad air. And as we move toward the modern era, you'll discover how this hybrid profession eventually split apart, surgery becoming a respected medical specialty requiring years of education, while barbering evolved into the grooming profession we know today, with that red and white pole as the last vestige of its medical past. So settle in, get comfortable, and prepare for a journey into a world where your haircut might be followed by having your veins opened, where the same hands that trimmed your beard might next amputate your neighbour's gangrenous foot. A world both familiar and alien, fascinating and horrifying. The world of the medieval barber-surgeon is about to unfold before you, in all its blood-stained, peculiar glory. And who knows, perhaps by the end of our tale you'll have drifted off to sleep, peaceful in the knowledge that you live in an age of anesthesia, antibiotics, and practitioners who stick to either your hair or your health, but never both. As the first light of dawn breaks through the narrow windows of a monastery, a monk moves quietly through the dormitory, his leather case of tools hanging from his belt. He is not heading to prayer, not yet. First he must tend to his brothers. One by one he approaches their beds, checking for those who need his services. Some require a trim of their tonsure, that distinctive ring of hair that marks them as men of God. Others need treatment for ailments that plague their mortal bodies despite their spiritual devotion. With the same steady hands, he will both groom and heal. This monk is the earliest ancestor of the medieval barber-surgeon, a hybrid profession born in the quiet halls of monasteries long before it found its way to the noisy streets of medieval towns. The story of barber-surgeons begins here, in these sacred spaces, where the care of body and soul were seen as interconnected duties. Monasteries were not just places of prayer, but also centres of learning and healing. The monks preserved ancient medical texts from Greece and Rome, copying and studying the works of Galen and Hippocrates. Within their walls they established infirmaries to care for their brothers, and eventually for pilgrims and local people who had nowhere else to turn. But why did monks become the first to combine barbering and surgery? The answer lies partly in practicality. Monks needed regular grooming to maintain their tonsures, or the shaved crowns of their heads that symbolized their renunciation of worldly vanity. They already had the razors and shears necessary for this task. As they studied medical texts and began applying this knowledge, these same sharp tools proved useful for more than just haircuts. A steady hand that could shave a brother's head could also lance a boil, cut away dead flesh, or open a vein for bloodletting. There was also a deeper connection. Medieval medicine viewed the body as a balance of four humours: blood, phlegm, black bile, and yellow bile. When these humours fell out of balance, illness resulted. One way to restore this balance was through bloodletting, the controlled release of blood from the body. The monks, with their sharp razors and knowledge of anatomy from ancient texts, were well positioned to perform this common treatment. Soon their duties expanded beyond simple grooming to include a range of medical procedures. For several centuries, these monk barbers served as the primary healthcare providers within monastery walls and beyond. They developed skills in wound treatment, particularly valuable during the Crusades when injured knights returned in need of care. They became adept at bloodletting, tooth extraction, and even basic surgical procedures. Their practical approach stood in contrast to the university-educated physicians who would later emerge. Physicians who considered themselves too dignified to touch patients or spill blood. But this dual role of monks was not to last. By the 12th century, the church began to grow uncomfortable with its holy men spilling blood, even for medical purposes. The watershed moment came in 1163 with the Council of Tours, when Pope Alexander III declared that clergy should not perform operations involving bloodshed. The decree stated, "The Church abhors bloodshed," and prohibited monks from carrying out surgical procedures. This edict, reinforced by later church councils, effectively forced monks to abandon the surgical aspects of their medical practice. Nature abhors a vacuum, and so does human society. As monks stepped back from surgical procedures, someone needed to fill their role. Who better than the local barbers? These men already possessed the necessary sharp tools and steady hands from their grooming work. Many had likely learned some techniques from the monks themselves, Gradually, barbers began to take on the surgical procedures that monks could no longer perform, adding medical services to their grooming repertoire. In the bustling streets of medieval towns, the barber's shop evolved into something new, a place where you could get your beard trimmed and your boil lanced in the same visit. These early barber-surgeons occupied a unique social position. They weren't as educated or respected as physicians who studied at universities and treated nobility, but they were far more accessible to common people, providing hands-on care that physicians often considered beneath their dignity. As demand for their services grew, barber-surgeons began to organise. Guilds formed across Europe, in Paris by the late 13th century, in London by the early 14th. These guilds set standards for practice, regulated who could perform which procedures, and created systems of apprenticeship to train new barber-surgeons. In London, the Worshipful Company of Barbers was officially recognised in 1308, establishing barber surgery as a legitimate profession with its own regulations and hierarchy. The guild system transformed barber surgery from a loose collection of practitioners into a structured profession with standards and oversight. To become a barber surgeon, a boy would typically begin as an apprentice around age 12 to 14. For the next 7 years or more, he would live in his master's home, learning the trade by observation and gradually increasing participation. Only after completing this apprenticeship and producing a masterpiece, demonstrating his skills before guild officials, could he become a master barber surgeon with his own shop. Across Europe, the development of barber surgeons took different paths, each shaped by local customs and regulations. In France, the barber surgeons formed a particularly strong guild, eventually gaining enough status to challenge the dominance of physicians in certain areas of practice. In Germanic regions, barber surgeons often specialised further, with some focusing on specific procedures like cataract removal or hernia repair, travelling from town to town as specialists. England developed a particularly complex system, with multiple guilds competing for authority over different aspects of medical practice. The barber-surgeons shared territory with the Guild of Surgeons, leading to frequent disputes over who could perform which procedures. These conflicts wouldn't be fully resolved until 1540, when Henry VIII united the two groups into the Company of Barber-Surgeons, though even this union was fraught with tension between the barbers and the surgeons who considered themselves more sophisticated practitioners. Despite these variations, barber-surgeons throughout Europe shared certain commonalities. They were primarily practical healers, learning through apprenticeship rather than book learning. They performed a wide range of services from the mundane to the life-saving, from haircuts and shaves to tooth extractions, bloodletting, wound treatment, and even major operations like amputations. They worked with their hands, using tools that served dual purposes for grooming and surgery. And they were accessible to ordinary people in a way that university-trained physicians were not. The red and white pole that would become their universal symbol emerged during this period. There are several theories about its origins, but the most compelling connects it directly to bloodletting. When performing this procedure, the barber-surgeon would give the patient a pole to grip. Squeezing it would make the vein stand out more prominently. Afterward, the bloodied bandages would be washed and hung outside on the pole to dry, twisting in the wind around the pole. These white bandages, stained with red blood, created a spiral pattern that was eventually stylized into the painted pole we recognize today. By the late medieval period, barber surgeons had become fixtures in towns across Europe. In an age before hospitals as we know them, before formal medical education was widespread, these practical healers provided essential services to ordinary people. They occupied a middle ground in society, not as respected as physicians, but vital to community health nonetheless. Their shops became social centres where news was exchanged, local gossip shared, and a variety of ailments treated alongside haircuts and shaves. The monks who once combined grooming and healing within monastery walls would hardly recognise what their practical ministry had become, a thriving secular trade with its own complex social and professional structures. Yet the essential character remained. Practical people using practical skills to address human needs, both mundane and dire. As we step into a medieval barber-surgeon's shop in our next section, we'll see exactly what these practitioners had become by the height of their profession, and the extraordinary range of services they provided under one humble roof. As you push open the heavy door of the barber-surgeon's shop, it's not the sight that hits you first, it's the smell. A peculiar cocktail of scents assaults your nostrils. The metallic tang of blood, the earthy aroma of herbal remedies, the sharp bite of vinegar used to clean wounds, all layered over the more familiar smells of soap and hair tonics. It's not entirely unpleasant, not entirely medical, but distinctly unlike any modern establishment. This olfactory confusion perfectly captures the dual nature of the barber-surgeon's domain. Neither fully salon nor fully surgery, but a strange hybrid where the mundane and the medical coexist in intimate proximity. The barber's shop typically occupies a prominent position in town, often near the market square where foot traffic is heaviest. The building itself might be narrow but deep, squeezed between other shops in the crowded medieval streetscape. The front room faces the street, with shutters that open wide during business hours to admit light and advertise that the barber is open for customers. These shutters often double as counters when folded down, displaying ceramic bleeding bowls, perhaps a jar of leeches, or the tools of the trade to passers-by. Just inside the door, a bench lines the wall where waiting customers sit, watching the proceedings with varying degrees of interest or apprehension. Some are here for a simple trim, others for more invasive procedures. They wait together regardless, the social distinctions of the outside world temporarily suspended in this chamber of shared vulnerability. A noble might sit beside a merchant, both watching a farmer have his tooth extracted, all knowing they might soon be in that same chair. The focal point of the shop is the barber's chair, a sturdy wooden construction with arms for gripping during painful procedures. It's positioned to catch the best light from the windows, crucial for detailed work whether cutting hair or cutting flesh. Some more prosperous shops might have two chairs, allowing the master and his apprentice to work simultaneously. Above the chair, a small mirror might hang, polished metal rather than glass, offering a dim reflection for customers to admire their new appearance, though many procedures would leave them in no state to care about their looks. The walls tell the story of the barber-surgeon's craft better than any book could. Hanging from pegs and hooks are the tools of the trade, razors of various sizes, their handles often made of bone or wood, shears for cutting hair, lancets for bloodletting, bowls for catching blood, and perhaps more specialised instruments for tooth extraction or minor surgeries. These tools are displayed openly, not hidden away as modern surgical instruments would be. They serve as both advertisement and warning. This is a place where cutting happens, whether of hair or flesh. Shelves line another wall, holding glazed pottery jars of various sizes. These contain the barber-surgeon's pharmacopoeia, dried herbs for poultices and teas, ointments for wounds, styptic powders to stop bleeding, and perhaps more exotic ingredients like powdered unicorn horn, actually narwhal tusk, or mummy powder, literally ground up Egyptian mummies, for those who can afford such rarities. Labels might be simple pictograms rather than words in a time when literacy is uncommon. The barber-surgeon knows his inventory by sight, smell, and location. In one corner stands a basin and ewer for washing hands and rinsing razors, a nod to cleanliness, though not with our modern understanding of germ theory. The water might be changed a few times a day, or merely topped up as needed. Nearby, a small hearth or brazier provides heat for warming towels, boiling instruments, or heating cauterizing irons that will sear bleeding vessels closed after surgeries or amputations. The sight of these irons glowing red in the coals is enough to make waiting patients shift uncomfortably on their bench. The back of the shop holds a heavier table, reinforced to support the weight of a person. This is where more serious surgeries take place, somewhat removed from the street view, though still visible to waiting customers. Privacy is a luxury not yet invented for medical procedures. The table might have leather straps attached, not for some sinister purpose, but the practical need to restrain patients who will be fully conscious during excruciating operations. Nearby stands a smaller table holding larger surgical tools, bone saws, trepanning drills for skull operations, larger forceps and suturing needles with thread made from animal gut or flax. The floor is typically stone or hard-packed earth covered with rushes or straw, easy to sweep clean of hair clippings, and more grimly, able to absorb blood and other fluids that inevitably spill during a day's work. In busier shops, these floor coverings might be changed daily. In others, they accumulate the evidence of many procedures before being replaced. The sounds of the barber's shop create their own peculiar symphony. The metallic snip of shears cutting through hair provides a rhythmic backdrop. Conversation flows freely. The barber-surgeon is often a central figure in community gossip networks, hearing news from all social classes who pass through his doors. Laughter might suddenly be punctuated by a cry of pain as a tooth is extracted or a boil lanced. From the street come the calls of vendors, the clop of horse hooves, the general murmur of town life flowing past the open shutters. On busy days, the shop becomes a microcosm of the community itself. A nobleman might be getting his beard trimmed while discussing town politics with the barber. At the surgical table, a blacksmith might be having a work-related burn treated with herbal salves. A mother might bring in a child with an infected cut or a tooth in need of extraction. The barber-surgeon moves between these tasks with practiced ease, switching from cosmetic to medical work without pause. Apprentices hover nearby, watching every move, occasionally handed tools to clean or directed to hold a patient still. These boys, some as young as 10 or 12, live with their master, learning the trade through years of observation and gradually increasing responsibility. They might begin by sweeping hair, progress to lathering beards, then eventually assist with bloodletting, and after many years perform simple procedures themselves. The relationship between master and apprentice is that of parent and child, teacher and student, boss and worker all combined. The lighting in the shop comes primarily from windows and perhaps a few expensive candles or oil lamps for darker days. This makes the barber-surgeon's work seasonal. Complex procedures are best performed in summer months when daylight is plentiful. In winter, only the most urgent surgeries would be attempted in the limited hours of natural light. Artificial lighting is too dim and too costly for routine use. For the more prosperous barber-surgeons, the shop might have an upper floor or back room where the master and his family live, including any apprentices. The sounds and smells of the business permeate their domestic life. The boundary between work and home is fluid as that between barbering and surgery. For others, the shop doubles as living quarters, with pallets rolled out after closing and the family sleeping among the tools of their trade. The barber's shop serves functions beyond the purely medical or cosmetic. It is a social hub where men gather to exchange news and opinions. Some shops offer refreshments. A cup of ale or wine might help steady nerves before a bloodletting or tooth extraction, and coincidentally loosen tongues and purse strings. Music isn't uncommon. A barber with a talent for lute or pipe might entertain waiting customers, a tradition that would eventually evolve into the barbershop quartets of later centuries. Women are not absent from this space, though they might visit for different reasons than men. They come primarily for medical services rather than grooming, seeking treatment for themselves or bringing children for care. Some barber-surgeons specialize in women's ailments, though midwives and wise women provide much of the healthcare specifically for female complaints. As day fades into evening, the barber-surgeon closes his shutters, rinses his tools and sweeps the floor. The bleeding bowls are emptied, the razors stropped sharp for tomorrow's work. Perhaps he sorts through the teeth extracted that day. Some barber-surgeons keep these as grisly trophies or to show potential customers the source of others' pain that they've successfully eliminated. The shop grows quiet, but the smells linger, that distinctive blend of blood, herbs, hair tonics, and humanity that defines this unique space. This is the medieval barber's shop, a place of contradiction and necessity, where vanity and mortality meet under the same roof, attended by the same hands. It is a forerunner not just of modern barbershops and beauty salons, but also of medical clinics and operating theatres, a reminder of a time when these now separate domains were unified in a single tradesman with a remarkably diverse set of skills. And at the heart of this shop stands the barber-surgeon himself, armed with tools both familiar and frightening, ready to tend to the hair, teeth, and bleeding veins of anyone who walks through his door. The barber-surgeon's hands may have been his most important assets, steady, experienced, and dexterous, but it was his tools that extended his touch, allowing him to cut, extract, probe, and heal. These implements, displayed prominently in his shop or carried in leather pouches and wooden cases, tell us more about the practice of medieval medicine than any written text could. Each one represents a particular problem to be solved, a specific pain to be addressed, and sometimes a danger to be risked in the name of healing. Let's begin with the most iconic tool in the barber-surgeon's collection, the razor. Unlike modern safety razors with disposable blades, medieval razors were straight-edged instruments with folding handles, often crafted from a single piece of steel. The blade would be forged, ground to thinness, and then polished to achieve the necessary sharpness. The handle, frequently made of bone, horn, or hardwood, would be carved to provide a secure grip, essential when holding an edge that could just as easily slice an artery as trim a beard. These razors served dual purposes that perfectly embodied the barber-surgeon's hybrid profession. Their primary use was cosmetic, shaving beards and trimming hair according to the fashions of the day. But that same sharp edge made them ideal for surgical incisions, lancing boils, or opening superficial veins for bloodletting. A well-made razor might remain in use for decades, passed down from master to apprentice, developing a patina from countless contact with beard lather and human blood. Next to the razor in importance were the shears or scissors. Unlike modern scissors with their precise factory-made edges, medieval shears were hand-forged, often consisting of 2 blades connected by a spring bow. The barber-surgeon would use these for cutting hair, trimming beards too thick for the razor alone, and in medical practice for cutting away dead tissue, trimming bandages, or even cutting into flesh when a wider incision was needed than a razor could provide. Like the razor, a good pair of shears was a significant investment, kept sharp through regular honing and oiling. But it's when we move beyond these familiar grooming tools that the Barber-Surgeons collection becomes truly fascinating, and for modern sensibilities often disturbing. Consider the bloodletting toolkit, instruments designed specifically to release blood from the body in what was considered a therapeutic practice. At the centre of this kit was the Barber-Surgeon, a multi-bladed folding instrument that resembled a small pocket knife, except its blades were broad and short, designed not to cut deeply but to precisely nick a vein. A typical fleam might have several blades of different sizes to accommodate veins of varying thickness and locations on the body. Complementing the fleam was the lancet, a narrower, longer blade mounted on a slender handle used for more precise bloodletting or for opening abscesses and other small surgical procedures. The lancet required even greater skill to use than the fleam, as its potential to cut too deeply made it more dangerous in less experienced hands. Some barber-surgeons preferred the lancet for its versatility, using it for everything from bloodletting to minor surgeries, while others reserved it for specific procedures. To collect the blood drawn during these procedures, the barber-surgeon used bleeding bowls, shallow, rounded vessels often made of ceramic, tin, or occasionally brass for wealthier practitioners. These bowls were specially designed with a curved cutout on one side that could fit against the patient's neck, arm or leg, catching the blood as it flowed from the incision. Many had volume markings on the inside to measure how much blood had been taken, a critical consideration when the difference between therapeutic bloodletting and dangerous exsanguination might be just a few ounces. For patients who preferred bloodletting without direct cutting, the barber-surgeon offered cupping. This required a different set of tools, glass or horn cups of various sizes, along with a small alcohol lamp or candle. The cup would be heated briefly, then quickly placed on the skin. As the air inside cooled, it created suction, drawing blood to the surface. For wet cupping, the skin would first be lanced with small incisions, allowing the cup to draw out blood. For dry cupping, no incisions were made, and the treatment simply caused bruising and inflammation thought to draw bad humours to the surface. Perhaps the most feared tools in the barber-surgeon's arsenal were those related to tooth extraction. The dental key, resembling a large metal key with a claw at the end instead of the usual key bit, was a common extraction tool. The claw would be fitted over the offending tooth, the handle rotated, and the tooth literally levered out of the jawbone, a process as painful and potentially damaging as it sounds. Fragments of jawbone or tooth often remain behind, leading to infections and further suffering. An alternative to the dental key was the pelican, named for its resemblance to the bird's beak. This instrument had a curved claw that hooked over the tooth, with a fulcrum that rested against the gum line. By pulling the handle, the barber-surgeon would lift the tooth from its socket. It was marginally more precise than the dental key, but still brutally painful and traumatic. Dental forceps of various sizes and shapes rounded out the tooth extraction toolkit, used to grasp and remove teeth or fragments left behind by other methods. For more serious operations, the barber-surgeon possessed an array of larger tools that would make modern observers shudder. Chief among these was the amputation saw, a bone saw with a thin blade and fine teeth, designed to cut through limbs as quickly and cleanly as possible. Speed was essential in pre-anesthetic surgery, and an experienced barber-surgeon could remove a lower leg in under 2 minutes. The saw's handle was typically wooden, sometimes wrapped in leather for better grip even when slick with blood, and the blade was kept meticulously clean and sharp to reduce trauma during cutting. Accompanying the saw were large knives called catlings, long, straight-bladed knives used to cut through soft tissue before the bone saw was employed. These came in various lengths and shapes, some double-edged for making the initial circular cut through skin and muscle, others single-edged for more controlled incisions. A skilled operator would use these to slice cleanly through flesh and to minimize ragged edges that would be difficult to close afterward. For operations on the skull, performed to relieve pressure from injuries or to treat ailments thought to reside in the brain, the barber-surgeon used the trepanning drill. This hand-powered tool had a circular blade that could cut a hole in the skull when rotated back and forth. Some designs included a center pin that prevented the blade from suddenly plunging into the brain once it broke through the bone. The circular pieces of skull removed during these procedures were sometimes kept as charms or even ground up for use in other medicines. Nothing was wasted in medieval medicine, not even parts of the patient. After cutting came the equally important process of stopping blood loss and closing wounds. Cauterizing irons of various shapes and sizes were heated in a brazier until glowing red, then applied to bleeding vessels to seal them through heat. These irons might have ball-shaped ends for general cauterization, pointed tips for the reaching into the deep wounds, or flat surfaces for treating large areas. The smell of burning flesh was an inevitable part of any significant surgery, and the barber-surgeon became desensitized to both the odor and the sizzling sound of tissue being seared. For wounds that could be closed without cauterization, the barber-surgeon used curved needles and thread made from materials like silk, flax, or animal gut. Unlike the standardized sterile sutures of modern surgery, these materials varied widely in quality and were rarely if ever cleaned beyond a basic rinse. The needles themselves were precious tools, hand-forged and difficult to replace if broken, so they were used carefully and maintained meticulously, even if concepts of sterilization were centuries away. Beyond these primary tools, the barber-surgeon's collection included an assortment of specialized instruments: probes for exploring wounds, spatulas for mixing and applying ointments, forceps of various sizes for grasping and holding tissue, and tubes for draining fluids from body cavities. For urinary blockages, slender metal catheters were inserted into the urethra to allow urine to pass, an uncomfortable procedure made more bearable only by the alternative of a painfully distended bladder. How did the barber-surgeon transport these precious tools? Most owned a leather roll similar to a modern chef's knife roll, with pockets and loops sized for different instruments. When closed and tied, this kept the tools organized and protected during travel to patients' homes for house calls. For more substantial journeys or battlefield work, wooden boxes with fitted compartments might be used, sometimes lined with fabric to prevent the metal tools from clattering against each other and dulling their edges. Care of these tools was a daily ritual. After use, they would be wiped clean of blood and tissue, perhaps rinsed in water or vinegar, then dried thoroughly to prevent rust. Edges were honed on whetstones, moving from coarse to fine grits to achieve the necessary sharpness. Metal surfaces might be polished with fine ash to remove tarnish, and hinged instruments would be oiled to ensure smooth operation. This maintenance was often the task of apprentices, part of their gradual introduction to the tools they would someday wield themselves. The quality of a barber-surgeon's tools spoke volumes about his success and reputation. A prosperous practitioner might own silver-handled instruments or specialized tools imported from famous metalworking centers like Toledo in Spain or Milan in Italy. A struggling barber-surgeon might make do with fewer older implements, perhaps inherited or purchased second-hand from a retiring colleague. The tools were not just implements but investments, representing a significant portion of a barber-surgeon's wealth and professional identity. Notably absent from this medieval toolkit were two categories of instruments we take for granted today: diagnostic tools and anesthetic delivery devices. The barber-surgeon diagnosed primarily through observation, touch, and patient description, without the benefit of stethoscopes, blood pressure cuffs, or any form of imaging. And pain relief came primarily through oral administration of alcohol, opium preparations, or herbal sedatives. There were no syringes for local anesthetics, no masks for inhaled agents, no reliable way to render a patient fully unconscious without risk of death. This collection of tools, from the mundane razor to the fearsome bone saw, represented the full spectrum of the barber-surgeon's practice. Each implement was an extension of his knowledge and skill, a physical manifestation of his approach to healing. To modern eyes, they might seem crude, even barbaric, but in their time they were the cutting edge of medical technology, the best answer available to the eternal human problems of pain, disease, and injury. In the hands of an experienced practitioner, they could bring relief, healing, and sometimes even salvation from death, though not without cost, not without pain, and never without risk. With tools in hand, the barber-surgeon was ready to practice what was perhaps his most common medical procedure, bloodletting. Today, the deliberate draining of blood from a patient seems not just primitive but counterproductive, even dangerous. Yet for over 2,000 years, from ancient Greece to the late 19th century, bloodletting wasn't just accepted medicine. It was the cornerstone of treatment for countless ailments, performed on everyone from peasants to popes, labourers to kings. And in medieval Europe, no one was more intimately associated with this practice than the barber-surgeon, whose very symbol, the red and white pole, evolved from this bloody art. To understand bloodletting, we must first step into the medieval mind and its conception of human health. Since the time of Hippocrates and Galen, Western medicine had been dominated by the theory of the four humours: blood, phlegm, black bile, and yellow bile. These bodily fluids were thought to correspond to the four elements: air, water, earth, and fire, and the four qualities: hot, cold, dry, and moist. Perfect health existed only when these humours remained in perfect balance, a balance unique to each individual based on their age, gender, and natural constitution. Disease, by extension, was understood as an imbalance of these humours. Too much blood made one sanguine, overheated, flushed, prone to fevers and inflammation. Excess phlegm caused one to become phlegmatic, sluggish, pale, suffering from colds and respiratory problems. An overabundance of black bile led to melancholy, depression, insomnia, and digestive complaints. And too much yellow bile produced a choleric temperament, irritability, rashes, and liver problems. When a patient presented with symptoms suggesting an excess of blood, fever, redness, swelling, headaches, or simply being too full-blooded, the logical treatment was to remove some of this excess, and so the barber-surgeon would reach for his fleam or lancet, preparing to restore balance through controlled bleeding. The practice wasn't seen as dangerous or desperate. It was considered rational, even sophisticated medicine backed by the most respected medical authorities of the day. Bloodletting wasn't performed haphazardly. It followed intricate rules about timing, location, and amount. The medieval barber-surgeon would consult almanacs and astrological charts to determine the most favourable days for bleeding. Certain zodiac signs were thought to govern different parts of the body, and bleeding during the wrong astrological alignment could allegedly cause more harm than good. The phases of the moon were equally important. Many practitioners preferred the waxing moon for bloodletting, believing the body's fluids responded to lunar cycles just as ocean tides did. Even the time of day mattered. Morning was generally preferred, when the patient was rested but hadn't yet eaten a heavy meal. Seasons too played a role. Spring was considered ideal for preventative bloodletting, as the body was thought to produce excess blood during winter that needed removal before it could cause summer fevers. Once the timing was right, the barber-surgeon would select the proper vein based on the patient's symptoms and medieval concepts of anatomy. This choice wasn't arbitrary, but followed a complex mapping of the body that connected specific veins to specific organs and ailments. Headaches might call for bleeding from veins in the temples or forehead. Chest complaints suggested veins in the arm. Menstrual problems or lower body ailments pointed to veins in the ankle or foot. For most routine bloodletting, the median cubital vein in the crook of the elbow was preferred, the same vein used for most modern blood draws and IV placements. This large, accessible vein allowed for controlled bleeding with relatively low risk. The patient would sit in the barber's chair, arm extended, perhaps gripping a pole or staff to make the vein stand out more prominently. The barber-surgeon would apply a tight band above the elbow, similar to a modern tourniquet, causing the vein to bulge. After cleaning the area with wine or vinegar, not for sterility, which wasn't understood, but for ritual cleanliness, the barber-surgeon would make a quick, precise cut with the fleam or lancet. Blood would flow into a waiting bowl, typically calibrated to measure the amount drawn. A common bloodletting might remove anywhere from 4 to 16 ounces of blood, a significant amount when you consider that the entire human body contains only about 10 pints, 80 ounces. For modern comparison, a standard blood donation takes just under a pint, 16 ounces, and donors must wait weeks between donations to recover. Some patients underwent bloodletting regularly as preventative maintenance, especially the wealthy who could afford such care. A nobleman might be bled quarterly, coinciding with the changing seasons, to maintain his humoral balance. Others came only when ill, receiving bleeding as part of a comprehensive treatment that might also include purging, sweating, and dietary changes, all aimed at restoring humoral balance. But not all bloodletting involved direct venesection with sharp instruments. For patients who feared the knife or for conditions thought to require more localized blood removal, the barber-surgeon offered alternatives. Cupping, as we've seen, used a vacuum pressure to draw blood to the surface, either with or without small incisions. When performed without cutting, dry cupping, it caused extensive bruising, but no actual blood loss. With small cuts, wet cupping, it drew blood from capillaries rather than veins, allowing for a more diffuse blood removal from a specific area. Even more popular, particularly for localized inflammation or infections, was the application of leeches, a practice that gave us the term leech as an old name for doctors. The barber-surgeon would maintain a supply of medicinal leeches, hirudo medicinalis, kept in jars of water that were changed regularly to keep the creatures healthy. When needed, a leech would be applied to the affected area, a joint with gout, an infected wound, a bruise, or a black eye. The leech would attach, inject its natural anticoagulant, hirudin, and begin to draw blood, swelling to several times its original size before dropping off satisfied. Leeching was considered gentler than direct venesection, particularly appropriate for children, the elderly, or delicate areas of the body. It had the added benefit, unknown to medieval practitioners, of the leech's saliva containing anti-inflammatory and blood-thinning compounds that could actually provide some therapeutic benefit for certain conditions. This makes leech therapy one of the few medieval practices that has seen some legitimate revival in modern medicine, particularly in microsurgery and the treatment of venous congestion in reattached digits or tissue flaps. The experience of bloodletting varied dramatically depending on the skill of the practitioner and the condition of the patient. In the hands of an experienced barber-surgeon with sharp tools and good technique, a basic venesection might cause only moderate pain. A quick sting followed by the sensation of warmth as a blood flowed from the incision. A patient suffering from high blood pressure or certain inflammatory conditions might even feel temporary relief after bloodletting, reinforcing the belief in its efficacy. However, in less skilled hands or with dull instruments, the procedure could be excruciating and dangerous. Missed veins, multiple attempts, excessive blood loss or infections were common complications. Patients might faint during the procedure, something often attributed to the release of bad humours rather than the more obvious explanation of blood loss and pain. Some never recovered from excessive bleeding, making bloodletting itself a significant cause of iatrogenic, physician-caused, death throughout history. The aftercare for the bloodletting was relatively simple. Once the desired amount of blood had been removed, the barber-surgeon would clean the area again, apply pressure to stop the bleeding and bandage the wound. Patients were advised to rest, avoid strenuous activity, and follow dietary recommendations appropriate to their condition, typically avoiding foods thought to increase blood production for a short period. The bandages would be removed after a day or two, by which time the small incision had usually begun to heal. What's perhaps most remarkable about bloodletting is how long it persisted despite growing evidence of its limitations and dangers. Even as anatomy advanced and the circulatory system was properly understood, even as the humoral theory began to crumble under scientific scrutiny, bloodletting remained entrenched in medical practice. George Washington famously died in 1709 after being bled excessively for a throat infection, losing an estimated 40% of his blood volume in 24 hours at the hands of physicians still committed to this ancient practice. So why did people continue to believe in bloodletting despite its obvious risks? The answer lies partly in the power of tradition and authority. Galen and Hippocrates had recommended it, and their words carried enormous weight. Partly it was confirmation bias. Practitioners remembered the times patients improved after bleeding, perhaps despite the treatment rather than because of it, and forgot or rationalized the failures. And partly it was the occasional real benefit that bloodletting might provide in specific conditions like pulmonary edema or polycythemia, where reducing blood volume can genuinely help. For the medieval patient sitting in the barber-surgeon's chair, arm extended and blood flowing into the waiting bowl, none of these theoretical concerns would have mattered much. They simply trusted in a procedure that had been performed countless times before, on countless others, by practitioners whose red and white poles advertised their expertise in managing the most vital and visible of the four humours. The barber-surgeon, phlegm in hand, wasn't practicing primitive medicine by the standards of his day. He was performing the most sophisticated treatment available, balancing the body's fundamental substances in accordance with the best medical knowledge of his time. As the blood slowed and the bandage was applied, both practitioner and patient would have felt the satisfaction of a necessary medical intervention successfully completed. Humour was balanced, the excess removed, health potentially restored. That we now see this procedure so differently speaks not to their ignorance, but to the long, slow evolution of the medical understanding, a journey that continues today, making us wonder which of our own trusted medical practices future generations might view with similar bewilderment. With the bleeding done and the patient bandaged, the barber-surgeon would turn to another common complaint that brought people to his door, the eternal human struggle with dental pain. And for those suffering from toothache in medieval times, the barber-surgeon's chair was both the last resort and the only hope for relief, however brutal that relief might be. If the sight of blood flowing into a bowl made patients uneasy, it was nothing compared to the dread inspired by the barber-surgeon reaching for his dental tools. In a world without antibiotics, effective painkillers, or modern dental understanding, toothache was more than an inconvenience. It was a special kind of torture that could drive even the most stoic individual to desperate measures. The medieval mouth was a battleground of decay, infection, and pain, and the barber-surgeon was the frontline fighter in this endless, often losing war against dental suffering. Dental problems were ubiquitous in the Middle Ages. The diet, heavy in coarse bread that contained stone particles from the milling process, wore down teeth prematurely. Sugar was becoming more available to the wealthy, consequently suffered increasing rates of decay. Dental hygiene was rudimentary at best, or some people rubbed their teeth with rough cloths, used twigs as toothpicks, or rinsed with wine or herb-infused waters, but the concept of regular brushing was foreign to most. The result was predictable. By middle age, most medieval people had missing teeth, severe decay, chronic abscesses, or some combination of these problems. When pain became unbearable, and medieval people had high thresholds for discomfort, they would finally seek out the barber-surgeon. His approach to dentistry was practical and direct. Unlike physicians, who might prescribe complex herbal remedies based on humoral theory, the barber-surgeon dealt with dental problems mechanically. If a tooth hurt badly enough for someone to sit in his chair, it was coming out. There was rarely any middle ground or conservative treatment. The procedure began with an examination. The barber-surgeon would use a small metal probe to tap the patient's teeth, looking for the one that elicited the greatest pain response. Patients would point, often unable to precisely identify which tooth was causing their agony, as pain radiated throughout their jaw. Sometimes the culprit was obvious, visibly decayed, discoloured, or surrounded by swollen, inflamed gums with perhaps a telltale abscess draining alongside it. For the extraction itself, the patient would be positioned in the barber's chair, gripping the arms tightly in anticipation of what was to come. No effective local anaesthetics existed, though the barber-surgeon might offer various forms of mild pain relief, a shot of strong alcohol, a dose of opium if available and affordable, or herbs like henbane that had sedative properties. Some practitioners would apply mixtures containing the ingredients like clove oil, which does have mild numbing properties, to the gum around the offending tooth. Others might use extreme cold, applying cloth soaked in cold water or even snow when available to numb the area somewhat. None of these measures came close to preventing the excruciating pain of extraction. The barber-surgeon would select the appropriate tool based on the tooth's location and condition. For front teeth with single roots, simple forceps might suffice. These pincer-like tools would grip the tooth firmly, while the practitioner worked it loose with a rocking motion. For molars with multiple roots, the fearsome dental key or pelican would be employed. The dental key, as we've seen, operated like a corkscrew. Its claw would be fitted over the tooth, the handle turned, and the tooth literally levered out with considerable force. The sound, a sickening crack as the tooth or jawbone gave way, was almost as traumatic as the sensation. Blood would flow freely, sometimes accompanied by fragments of tooth or even jawbone. The pelican worked on a similar principle but with a different mechanical action, pulling rather than rotating the tooth out of its socket. Patients were instructed to hold onto the chair arms, or in some cases might be physically restrained by an assistant. Screaming was expected and unavoidable. Those waiting their turn would hear these cries from the shop floor, adding to their own dread and sometimes causing them to flee before their treatment. The barber-surgeon, for his part, worked as quickly as possible. Speed was considered a virtue in all surgery, but especially in dental extraction, where a prolonged procedure only extended the patient's agony. Tooth extraction was not merely painful but dangerous. Without understanding of infection control, procedures frequently introduced bacteria deep into the jaw. The instruments were cleaned only superficially between patients, making cross-contamination common. Incomplete extractions left root fragments that could fester for years. Excessive force could fracture the jawbone. Bleeding might be difficult to control, particularly in patients with clotting disorders. Even when technically successful, extraction created an open wound in an inherently bacteria-laden environment, leading to frequent post-procedure infections. After extraction, the barber-surgeon would have the patient rinse with wine, vinegar or salt water, measures that might have provided some limited antiseptic benefit through sheer luck rather than understanding. Bleeding was typically controlled by having the patient bite down on linen pads, though persistent hemorrhage might be treated with cautery or styptic powders. Patients were advised to avoid hot foods and drinks, to rest, and sometimes to use herbal mouth rinses in the days following. But tooth extraction wasn't the only dental procedure offered in the medieval barber's shop. For those with less severe decay or who couldn't face extraction, the barber-surgeon might perform primitive fillings. These bore little resemblance to modern dental restorations. Typically, the practitioner would scrape out the obvious decay using small metal picks, a painful process in itself. The resulting cavity would then be filled with various substances, softened beeswax, gum, arabic, or pastes made from powdered herbs and resins. Metal fillings existed but were rare and expensive, typically lead or tin beaten into thin leaves that could be packed into the cavity. These fillings provided temporary relief at best. Without proper cleaning of the decay, infection often continued beneath the filling. The materials weren't durable, wearing away or falling out within months. At worst, they simply trapped infection inside the tooth, leading to abscess formation and even more severe pain than the original decay. For loose teeth, a common problem in an age of periodontal disease, the barber-surgeon might attempt a primitive form of dental splinting. Using fine gold or silver wire, he would bind the loose tooth to its more stable neighbours, creating a crude but sometimes effective stabilisation. This technique, known since ancient Roman times, was typically only available to wealthy patients who could afford the precious metals involved. Scaling, the removal of tartar and calculus from teeth, was another service offered to those who could afford preventative care. Using small metal scrapers, the barber-surgeon would painstakingly chip away at the hardened deposits. Without good lighting or magnification, this was crude work, often damaging the gums and tooth surfaces, while still leaving deposits in hard-to-reach areas. Nevertheless, it might help preserve teeth somewhat longer than leaving the calculus untreated. For those who had already lost teeth, which included most adults past their 30s, replacement options were limited but did exist. The wealthy might obtain crude dentures made from carved bone, ivory, or wood. These prosthetics were uncomfortable, poorly fitted, and difficult to eat with, but provided some cosmetic improvement and limited functional benefit. They were secured with metal springs or wires that added to their discomfort. Some barber-surgeons specialised in these dental prosthetics, developing considerable artistic skill in carving replacements that matched the size and shape of natural teeth. More ghoulishly, there was a market for real human teeth as replacements. These might be purchased from the poor who were willing to sell healthy teeth for money, or harvested from corpses. These donor teeth could be wired to neighbouring teeth or to crude plates. While providing a more natural appearance than artificial materials, they rarely took hold in the recipient's mouth, quickly decaying or causing severe infections. Nevertheless, the practice continued well into the 18th century. For patients suffering from bad breath, almost everyone in an age of poor dental hygiene, the barber-surgeon offered various mouth rinses and dentifrices. These might contain mint, cloves, cinnamon, or other strong spices to mask odours, along with abrasives like crushed chalk or powdered shells to clean tooth surfaces. Some preparations included honey, which we now know has mild antibacterial properties, though its sugar content would have contributed further to decay. Pain management for dental conditions, beyond the limited options available during procedures, typically involved poultices applied to the face externally. Hot compresses might bring some relief by increasing blood flow to the area. Various herbal preparations, cloves, willow bark containing natural salicylates related to aspirin, or opium derivatives for the fortunate, could provide temporary numbing or sedation. Many folk remedies involved sympathetic magic or religious elements. Prayers to St. Apollonia, the patron saint of toothache, who had her teeth broken during martyrdom, charms worn around the neck, or rituals performed at specific phases of the moon. The barber-surgeon's approach to dentistry perfectly embodied the medieval approach to medicine as a whole, practical rather than theoretical, focused on alleviating immediate suffering rather than understanding underlying causes, limited by the technology and knowledge of the age, but remarkably resourceful within those constraints. When modern dentists use forceps for extractions, they were using refined descendants of tools that would be recognizable to their medieval predecessors, a sobering reminder that while techniques and understanding have advanced tremendously, some of the basic mechanical principles of dental treatment remain unchanged across the centuries. As the patient staggered from the barber's chair, mouth packed with cloth to staunch the bleeding from a fresh extraction, they might consider themselves fortunate compared to those requiring more invasive procedures. For while dental work was excruciating, it was brief. Those needing true surgery, the removal of limbs, excision of tumours, or repair of severe injuries, faced ordeals of an entirely different magnitude, testing the limits of both patient endurance and barber-surgeon skill. While bloodletting and tooth-pulling were routine affairs in the barber-surgeon's day, it was in the realm of true surgery that his skills were most severely tested. Here, in procedures where life and death balanced on the edge of his knife, the barber-surgeon performed work that would make even modern medical professionals blanch. Without antibiotics, with only the most rudimentary understanding of anatomy, and with pain management that was frighteningly inadequate, he cut into living bodies, removed limbs, excised tumours, and somehow, sometimes saved lives that would otherwise have been lost. The medieval operating theatre bore little resemblance to its modern counterpart. There were no gleaming tiles, no bright overhead lights, no monitors tracking vital signs. Surgery might take place in the back of the barber's shop on that heavy wooden table we encountered earlier, or in the patient's home, or even on a battlefield with nothing but blood-soaked ground beneath the patient. Hygiene as we understand it didn't exist. The concept of invisible microorganisms causing infection was centuries away. The barber-surgeon would operate in his regular clothes, perhaps with an apron, to protect them from blood, his hands rinsed in wine or vinegar, but not truly sterile by any modern standard. The most common major surgery, and the one that defined the barber-surgeon's reputation, was amputation, in an age before antibiotics, compound fractures where bone breaks through skin, severe crush injuries, or advancing gangrene left few options. Once infection took hold in a limb, death was the likely outcome, unless the affected part was removed. Battlefield surgeons became particularly adept at this grim procedure, performing dozens of amputations in a single day following major conflicts. Preparation for an amputation began with assembling the necessary tools: the amputation knife for cutting through soft tissue, the bone saw for severing the limb, cauterizing irons heating in a brazier to seal bleeding vessels, needles and thread for any necessary suturing, and bandages, lots of bandages, to wrap the stump. Assistants would be positioned to hold the patient down, for this was surgery performed on the fully conscious. The patient, already suffering from the injury or condition necessitating amputation, would be given what limited pain management was available. A shot of strong alcohol, brandy or whiskey, was standard. If available and affordable, opium preparations might be administered, either as laudanum, opium dissolved in alcohol, or as smoked opium for wealthier patients. Herbal concoctions containing henbane, mandrake, or hemlock, all powerful but dangerous sedatives, might be employed. In battlefield settings, the patient might simply bite down on a leather strap or piece of wood. None of these measures provided anything approaching modern anesthesia. At best, they took the edge off, rendered the patient somewhat delirious, or gave them something to focus on besides the unimaginable pain to come. The barber-surgeon knew this well. The measure of his skill was not just his technical ability, but his speed. A good amputation was a fast amputation. The quicker the cutting was done, the better the patient's chances of surviving both the immediate shock and the subsequent trauma. With assistants holding the patient immobile, a minimum of 4 strong men for an adult patient, the procedure would begin. First, the barber-surgeon would apply a tourniquet above the site of amputation, using a strap or cord tightened with a stick that could be twisted to control pressure. This reduced blood loss during the procedure. though it was a crude method by modern standards and carried its own risks if left in place too long. Next came the incision. Using the amputation knife, a curved blade with a sharp tip, the barber-surgeon would make a circular cut through the skin and muscle, down to the bone in a single smooth motion if possible. The most skilled practitioners could complete this step in seconds. The first cut was typically made slightly below where the final amputation would occur, allowing for a flap of skin to be preserved that would later cover the stump. With the soft tissue severed, the bone saw came next. Its thin blade would be applied to the exposed bone and drawn back and forth in quick practice strokes. This was often the most difficult part for observers to witness. The sound of saw teeth grinding through living bone, the patient's screams reaching new heights, the vibration of the limb as it was severed. A skilled barber surgeon might take as little as 30 seconds to cut through a thigh bone, perhaps 15 for the smaller bones of the arm. Once the limb was removed, the real race against death began. The major arteries, now spurting bright red blood with each heartbeat, needed to be closed immediately. The most common method was cauterization. Those irons heating in the brazier would be applied directly to the bleeding vessels, searing them closed with a sizzle and the sickening smell of burning flesh. Later medieval surgeons sometimes used ligatures, tying off individual blood vessels with thread, but this technique was slower and ironically led to higher infection rates in the pre-antiseptic era. With bleeding controlled, the barber surgeon would shape the stump, the preserved flap of skin would be pulled over the end of the bone, additional small blood vessels tied or cauterized as needed, and the whole thing sewn closed with needle and thread, typically silk or linen thread, sometimes coated with wax. The final dressing consisted of the layers of linen bandages, perhaps with herbal preparations like comfrey or plantain applied directly to the wound for their perceived healing properties. Throughout this entire process, which might take between 2 and 10 minutes depending on the limb and the surgeon's skill, the patient was awake, feeling everything. Many fainted from pain or shock. Some died on the table from blood loss, heart failure. It was due to the extreme stress, or simply the overwhelming trauma to the system. Those who survived the procedure itself still faced daunting odds. Infection was almost guaranteed to some degree, and death rates from post-amputation complications remained extremely high. Yet for all its horrors, amputation saved lives that would otherwise have been lost. A gangrenous limb left attached meant certain death. A compound fracture untreated inevitably led to infection and sepsis. Amputation offered a chance, however slim, and the barber surgeons who performed it with skill and speed were, in their own brutal way, healers deserving of the name. Amputation was just one of many surgeries in the barber surgeon's repertoire. Tumour removal represented another common procedure, particularly for external growths that could be easily accessed. Using knives, scissors, and cauterizing irons, the barber surgeon would excise visible tumours from the skin, scalp, or accessible areas like the breast or neck. Without microscopic examination or understanding of cancer's spread, these procedures were often incomplete, removing only the visible mass and leaving cancerous cells behind to regrow. Nevertheless, they might provide temporary relief or, in the case of benign growths, an actual cure. Battlefield surgery extended beyond amputation to include treatment of arrow and sword wounds, removal of embedded objects, and crude suturing of major lacerations. The barber surgeon might probe wounds with fingers or special instruments, attempting to extract arrowheads, broken knife tips, or splinters of wood or metal. Gut wounds, injuries to the abdomen penetrating the intestines, were recognized as particularly deadly with survival rates near zero. Nevertheless, barber surgeons sometimes attempted to clean and close such injuries, offering at least a small chance where none existed otherwise. One of the most dramatic and technically challenging procedures was the removal of bladder stones. In an age of poor hydration, mineral-laden water, and diets that promoted stone formation, bladder stones were agonizingly common. When they grew too large to pass naturally, the only option was surgical removal, a procedure called lithotomy. The patient would be bound in a sitting position with knees drawn up and spread apart. An assistant would apply pressure to the abdomen while the barber surgeon made an incision between the scrotum and anus in men, or into the bladder through the vaginal wall in women. Specialized forceps would then be inserted to grasp and remove the stone. Lithotomy was excruciatingly painful and carried extreme risks of infection, incontinence, and death. Yet the alternative, a lifetime of agonizing pain as the stone grew larger, led many to choose the procedure despite its dangers. Specialized stone cutters developed, who traveled from town to town performing only this operation, sometimes achieving considerable fame if their success rates were higher than average. Perhaps the most visually dramatic procedure, and one that has captured the modern imagination, was trepanning, the creation of a hole in the skull to access the brain. Trepanning had ancient origins dating back to prehistoric times and continued through the medieval period. The procedure might be performed to relieve pressure after head trauma, to treat seizures or severe headaches, or to release demons thought to cause mental illness. Using a specialized drill called a trepan, the barber-surgeon would carefully bore through the skull, creating a circular opening. The bone disc removed was sometimes kept as a charm or ground into powder for medicinal use. Great care had to be taken not to pierce the dura mater, the tough membrane covering the brain, though accidental penetration was common. The hole might be left open, covered with a piece of cloth or leather, or in some cases a fitted piece of precious metal might be crafted to cover the opening for wealthy patients. Remarkably, archaeological evidence shows that many trepanning patients survived the procedure and lived for years afterward, as demonstrated by healing around the bone edges. This suggests that despite the primitive conditions, some barber surgeons achieved significant success with this alarming operation. For women, the barber surgeon might perform caesarean sections, though almost exclusively on mothers who had already died in childbirth, in an attempt to save the infant. The procedure on living women was considered a death sentence due to blood loss and infection, performed only in the most desperate circumstances when both mother and child would otherwise perish. A few rare accounts exist of women surviving the procedure when performed by particularly skilled surgeons, but these were exceptional cases that acquired an almost mythical status. Hernia repairs represented another common surgery. Inguinal hernias, where a portion of intestine protrudes through a weakness in the abdominal wall near the groin, were particularly common in an age of heavy manual labour. The barber surgeon would cut into the affected area, attempt to push the protruding intestine back into place, and then stitch the muscle defect closed. Unfortunately, without proper understanding of anatomy or strong enough materials, these repairs frequently failed, with the hernia recurring within months or years. Across all these procedures, certain commonalities existed. Speed was universally valued, the faster the operation, the less blood lost and trauma experienced. This led to a strange paradox where the best surgeons were often those who spent the least time operating. Preparation was minimal by the modern standards, perhaps a dose of alcohol or opium, a quick cleaning of the area with wine, a positioning of assistants to hold the patient, and then straight to cutting. Post-operative care consisted mainly of bandaging, some herbal applications thought to promote healing, and prayer, lots of prayer. The tools, while specialized, were simple compared to modern surgical instruments. A good knife, strong forceps, a reliable bone saw, cauterizing irons, and sturdy needles could handle most procedures. Innovations came not in the form of new equipment, but in technique, ways of cutting that reduced blood loss, methods of suturing that promoted better healing, approaches to specific problems refined through harsh experience. Some barber surgeons achieved remarkable fame for their surgical skills. Ambroise Paré, a 16th century French barber surgeon, revolutionized military surgery by replacing cauterization with vessel ligation and developing new techniques for battlefield medicine. His works were translated and studied across Europe, elevating the entire profession. Others became known for particular specialties, reliable amputations, successful tumor removals, or high survival rates for particular procedures. The mortality rates for medieval surgery were appalling by modern standards. Infection claimed countless lives in the days and weeks following otherwise successful operations. Blood loss during the procedure killed many patients before the surgery was even complete. Pain and shock contributed to heart failure in others. And yet, when we consider that the alternative was often certain death from the original condition, the value of even these crude interventions becomes clear. Some patients did survive, some lives were extended, some suffering was relieved, however brutally. It would be easy to view medieval surgery as simple butchery, to dismiss the barber surgeons as ignorant and cruel. But this would miss the essential truth of their work. They operated at the absolute limits of medical knowledge available in their time. They used the tools and techniques they had, however inadequate, to fight against death and suffering. And sometimes, against all odds, they won these battles. As the patient was carried away from the operating table, alive if traumatized, the barber-surgeon would clean his bloodied tools, wash his hands, and prepare for his next case, continuing the ancient and honourable work of healing by hand, one patient at a time. Having completed the day's surgeries, the barber-surgeon might turn his attention back to the more mundane aspects of his profession. For while blood and bone might be the dramatic highlights of his practice, much of his daily work involved the far more ordinary business of cutting hair, trimming beards, and attending to the grooming needs of his community, the other face of his dual profession. After watching the barber-surgeon perform such grisly procedures, it might be hard to imagine that these same hands would then style your hair or trim your beard. Yet this duality defined the profession. The barber-surgeon wasn't just a man of medicine, but a craftsman of appearance, a shaper of identity through grooming. And while we've dwelled in the bloody chambers of their surgical practice, let's turn now to the more fragrant, though no less fascinating, world of medieval beauty treatments. As the bone saw is set aside and the bloodied apron removed, the barber-surgeon transforms before your eyes. His demeanour shifts, his conversation lightens, and he reaches for tools far less intimidating, though perhaps no less sharp. The razor, the shears, the comb, these were the everyday implements that actually kept most barber-surgeons in business. After all, not everyone needed a tooth pulled or an arm removed, but nearly everyone needed a haircut. A gentleman enters the shop, his beard wild and unruly, his hair overgrown beneath a worn cap. The barber welcomes him, gestures to the chair, the same chair where hours earlier someone might have gripped the arms in pain during a procedure. But now it's simply a place of transformation. The customer settles in, and the barber drapes a cloth around his shoulders, protection from the cascade of hair about to fall. For men of status, a haircut wasn't simply the trimming of excess length. It was a statement of identity, of place in society. The noble required a style befitting his station, perhaps shorter on the sides, fuller on top, a fashion that marked him as a man of means. The clergy had their distinctive tonsures, the crown of the head shaved to symbolise their devotion to God. Merchants might choose more practical styles, while peasants often made do with simple utilitarian cuts performed not by a barber, but by family members with whatever shears were available. But for those who could afford the barber's services, the experience was almost ritual. The barber would wet the hair with scented water, combing through tangles with a wooden or bone comb. The shears would snip with rhythmic precision, hair falling in clumps to join the day's accumulation on the rush-strewn floor. The barber might share the latest town gossip or political news as he worked. His shop a centre of community information long before newspapers became common. Beards received even more attention than hair in many periods. They weren't merely facial hair, but expressions of masculinity, wealth, profession, and even religious conviction. The barber-surgeon was an artist of the beard, sculpting it to match the latest fashion or a client's particular wishes. A wealthy merchant might request his beard be trimmed to a dignified point, perhaps with the moustache waxed to elegant curls. A knight might prefer something shorter that would fit comfortably under a helmet. And throughout the medieval period, styles shifted dramatically, from the clean-shaven Norman fashion after the conquest of England to the full, luxurious beards popular during later centuries. The tools for this work were specialised and often beautiful. Fine scissors with decorative handles for precise trimming, razors of polished steel, honed to incredible sharpness on leather strops, special combs, some with teeth of different widths on either side for different grooming tasks. The barber would keep these tools clean and sharp, displaying them prominently as evidence of his skill and care. The process of a shave was an art form in itself. First, hot water to soften the beard, then a scented soap or cream worked into a lather with a brush made from badger hair or boar bristles. The razor would glide across the skin with practiced strokes, the barber's fingers pulling the skin taut to prevent nicks. Finally, a rinse with cool water and perhaps an astringent liquid, wine, vinegar or alum water, to close the pores and prevent infection. A truly luxurious shave might conclude with a fragrant oil or balm rubbed into the skin. But grooming extended beyond hair and beards. The medieval period had its own beauty standards and cosmetic concerns, and the barber-surgeon addressed many of these as well. Warts, moles, and skin blemishes all fell under his domain. Using small sharp knives or caustic substances like quicklime or sulfuric acid, he would remove these unwanted marks. The procedures were painful, often left scars, and sometimes caused infections, but the desire for clear skin drove many to endure them nonetheless. For the wealthy, especially women of the court, the barber might offer more elaborate cosmetic services. The ideal complexion was pale, unblemished, and youthful. To achieve this, various creams and potions were applied, some harmless, others decidedly toxic. Lead-based face powders provided the desired whiteness, but slowly poisoned the wearer. Rouge made from cinnabar contained mercury. Belladonna drops dilated the pupils for a wide-eyed youthful appearance at the cost of blurred vision and potential blindness. The barber didn't always make these preparations himself. Many were created by apothecaries or the women themselves, following traditional recipes, but he often applied them or advised on their use. He might also offer hair removal services using depilatory creams made from caustic lime and arsenic, or simple plucking using tweezers. Eyebrows were shaped, sometimes removed entirely and redrawn with coal or charcoal to match the fashionable thin, high arch. Hair colouring, too, fell within his expertise. Grey hair could be darkened with preparations made from walnut shells, oak apples or iron filings steeped in vinegar. Blonde hair, highly prized for women, could be achieved through mixtures of saffron, celandine and oil, or by spending hours in the sun with the hair soaked in lemon juice or stale urine, the ammonia acting as a powerful lightening agent. For women, hair was a particular point of pride and distinction. Unmarried women often wore their hair loose and flowing as a sign of their maiden status, while married women typically covered their hair with veils, hoods, or elaborate headdresses. The barber might not always style women's hair, this was often the domain of ladies' maids or female family members, but he would trim and shape it when needed. Ear piercing was another service offered, particularly for women, but sometimes for men as well, especially sailors who believed that gold earrings improved their eyesight and protected against drowning. The procedure was simple but not without risk. A needle heated in flame, a piece of cork behind the earlobe, a quick push-through, followed by the insertion of a thread or wire to keep the hole open until it healed. Infection was common, sometimes leading to more serious complications. Beyond these specific services, the barber-surgeon's shop often served as a general centre for hygiene in an age when private bathrooms were rare. Some larger establishments connected to bathhouses, offering full-body bathing services. The customer would soak in a wooden tub filled with hot water, perhaps scented with herbs or flower petals. The barber or an assistant would scrub the body with soap, trim nails, clean ears, and generally refresh the patron. These combined barber bathhouses were particularly common in German-speaking regions and much of Eastern Europe. In more modest establishments, the barber might simply offer hand and foot washing, nail trimming, and ear cleaning using small metal picks designed to remove wax and debris. These mundane services were surprisingly important in an era when personal hygiene was difficult to maintain and dirt was an inescapable part of daily life. The range of cosmetic corrections available grew as the medieval period progressed into the Renaissance. Beauty marks, small patches of black silk or velvet, were applied to hide scars or blemishes or simply as fashion statements. The barber might create these custom patches or apply them for special occasions. Teeth were cleaned and whitened using abrasive powders made from crushed shells, bones, or brick dust mixed with honey or oil, effective at removing stains but also wearing away enamel over time. These grooming and cosmetic services formed the steady, reliable income for most barber-surgeons. While dramatic surgeries might be remembered in stories and earned significant fees, the daily work of cutting hair, trimming beards, and helping clients look their best provided the consistent business that kept shops open year after year. The barber-surgeon was, in many ways, more barber than surgeon for much of his working life. And this duality created a unique social position. The barber-surgeon touched people, literally and figuratively, in ways few others did. He knew the shape of a nobleman's skull beneath his dignified wig. He saw the scars a warrior hid beneath his beard. He heard the whispered requests for cosmetic treatments to cover the marks of age or disease. In touching heads and faces day after day, year after year, he gained an intimate knowledge of his community that few others possessed. So while we may remember the barber-surgeon for his bloodletting bowls and bone saws, perhaps we should also recall the gentler tools of his trade, the comb, the razor, the scissors that helped shape how medieval people presented themselves to the world. For in both his medical and his grooming roles, the barber-surgeon's hands changed lives. one careful cut at a time. From the skilled hands that shaped beards and removed warts, we turn now to how those hands became skilled in the first place. For the barber-surgeon didn't simply pick up a razor one day and begin slicing into beards and bodies. His journey began much earlier, usually as a boy no more than 10 or 12 years old, standing nervously at the door of a master's shop, about to enter a world that would consume the next 7 to 10 years of his young life. The path to becoming a barber-surgeon began with apprenticeship, that ancient system of training that passed knowledge from generation to generation through direct experience rather than books or lectures. A boy's parents might select this trade for various reasons. Perhaps they knew the local barber-surgeon and saw opportunity in his prosperous shop. Or maybe the boy had shown dexterity with his hands, a crucial quality for someone who would wield sharp blades near throats and arteries. Sometimes the choice was simply practical. Barber-surgeons were needed in every town, making it a reliable trade even in uncertain times. Once selected, the boy's family would approach a master barber-surgeon to discuss terms. This was no small matter. The master would be taking responsibility for feeding, housing and training the child for many years. A contract would be drawn up, often with a notary present, stipulating the exact conditions of the apprenticeship. The family typically paid a fee to the master, a significant sum that might represent years of saving. In return, the master promised to teach all aspects of the trade, from the simplest tasks to the most complex surgical procedures. On the appointed day, the boy would arrive at his new home, for that's what the barber-surgeon's shop would become. He wouldn't return to his family, except perhaps for occasional visits during the festivals. His bed might be a simple pallet in a corner of the shop or a small room shared with other apprentices. His possessions would be few. Perhaps a change of clothes, a small knife for eating, maybe a trinket from home to ease the inevitable homesickness. The first year of apprenticeship had little to do with the glamour of surgery, or even the basic craft of haircutting. Instead, the new apprentice found himself assigned the most menial tasks imaginable. He swept the floor countless times each day, gathering the fallen hair and blood-soaked rushes. He emptied chamber pots used by customers and the master's family. He fetched water from the town well, hauling heavy buckets up narrow stairs. He stoked fires, ran errands, and delivered messages across town. These tasks might seem unrelated to the barber-surgeon's craft, but they served important purposes. They taught the boy endurance, attention to detail, and obedience, all crucial qualities for someone who would eventually perform delicate procedures where mistakes could be fatal. They also firmly established the hierarchy of the shop, placing the apprentice at the bottom of a ladder he would spend years climbing. The most important early task for any apprentice was tool maintenance. Each evening, after the last customer had left, the boy would carefully clean every instrument used that day. Razors and lancets would be washed, dried and oiled to prevent rust. Shears would be wiped clean and their hinges checked. Bleeding bowls would be scrubbed until they gleamed. Through this daily ritual, the apprentice learned to recognize each tool, understand its purpose, and appreciate the importance of cleanliness, a concept that, while not understood in terms of germ theory, was still valued for aesthetic and practical reasons. The apprentice also learned to prepare the materials the master needed, mixing lathers for shearing, preparing astringent solutions, grinding herbs for poultices, and melting wax for depilatory treatments. He watched carefully as the master worked, absorbing techniques through observation long before he was allowed to attempt them himself. By the second year, if the boy had proved himself diligent and careful, he might be allowed to begin practicing on less valuable customers. The local beggar might receive a free shave in exchange for allowing an apprentice to scrape a blade across his weathered cheeks. A labourer might get a discounted haircut from these untested hands. The results were often uneven, sometimes bloody, but this was how skills developed, through practice on those who couldn't afford to complain too loudly about nicks and uneven edges. As the apprentice entered his third and fourth years, his responsibilities gradually expanded. He might be trusted to perform simple bloodletting procedures, applying leeches or cups, rather than using the more dangerous lancet. He would learn to extract teeth, beginning with those already loosened by disease rather than firmly rooted ones. He would assist the master during surgeries, holding limbs steady, passing instruments, and observing the techniques used for different conditions. The education wasn't entirely practical. In the evenings, especially during winter when customers were fewer, the master might lecture his apprentices on the theory behind their craft. He would explain the 4 humours that governed health: blood, phlegm, black bile, and yellow bile. He would describe how the positions of stars and planets influenced different parts of the body and thus determined the timing of treatments. He would share the signs that indicated which humour was in excess and which treatments would restore balance. Much of this theoretical knowledge was passed down orally, but some masters possessed precious books or manuscripts with anatomical drawings and medical recipes. These might be brought out on special occasions, the master running his finger along the Latin text, translating for his apprentices, pointing out the illustrations of veins, organs, and surgical procedures. The apprentice was expected to commit these teachings to memory, as books were rare and expensive, and most barber-surgeons would practice their entire lives without owning one. By the 5th year, an apprentice would begin to take on more complex procedures under supervision. He would perform bloodletting with a lancet, making precise incisions in veins. He would stitch wounds, set simple fractures, and lance boils. He would learn to identify different types of tumours and which could safely be removed. His hands, once clumsy with the razor, would become steady and confident, guided by experience and the stern corrections of his master. These middle years of apprenticeship were often the most difficult. The initial excitement had worn off, but full mastery remained distant. The work was physically demanding, standing for hours, bending over patients, maintaining precise control of sharp instruments despite tired muscles. Many apprentices suffered injuries themselves during this period, cutting their own fingers or accidentally pricking themselves with bloodletting tools, sometimes with serious consequences if the blood came from an infected patient. The relationship between master and apprentice was complex. The master was teacher, employer, surrogate parent, and sometimes harsh disciplinarian. Mistakes might be punished with verbal reprimands, extra chores, or even physical blows in an age when such correction was considered appropriate. Yet many masters also developed genuine affection for their apprentices, treating them almost as sons, particularly if they showed exceptional promise. By the 6th or 7th year, the apprentice would handle most routine procedures independently, with the master overseeing only the most complicated cases. The young man, for he would now be approaching adulthood, would have regular customers who asked specifically for his services, recognizing his growing skill. He would train newer apprentices, passing on what he had learned, reinforcing his own knowledge through teaching. As the apprenticeship neared its end, thoughts turned to the final test, the masterpiece. This varied by region and guild, but typically required the apprentice to demonstrate his skills before the guild masters. He might need to perform several different procedures, perhaps extracting a tooth, lancing a boil, and bloodletting, while explaining the theory behind each action. He would be questioned about anatomy, the properties of medicinal herbs, and the appropriate treatments for various conditions. Some guilds required a literal masterpiece, a specially crafted set of surgical tools made by the apprentice himself, working with a blacksmith to forge and finish the instruments according to precise specifications. These would be examined closely for quality of craftsmanship and suitability for their intended use. If the apprentice passed these tests, he would receive his certificate from the guild, officially recognizing him as a journeyman barber-surgeon. This wasn't yet full mastery. That would come only after several more years of practice, often travelling from town to town to work in different shops and learn regional variations in technique. But it marked the end of his formal apprenticeship and the beginning of his professional life. The new journeymen faced important choices. Some remained with their masters, working as employees in the shop where they trained. Others sought positions in different towns or even different countries, eager to expand their knowledge and experience. The most ambitious began saving to open their own shops, though this required significant capital for tools, furnishings, and guild fees. This system of apprenticeship ensured that knowledge passed from generation to generation with remarkable consistency. The barber-surgeon of 1500 used many of the same techniques as his predecessor from 1300, having learned them through the same immersive hands-on process. Innovation occurred slowly, usually when a particularly inventive master developed a new tool or technique that proved successful enough to be adopted by others in the guild. Through years of watching, practicing, failing, and eventually succeeding, the boy who once swept hair from the floor transformed into a skilled practitioner capable of both artistic haircuts and life-saving surgeries. His hands, once soft and uncertain, became sure instruments of his craft, guided by knowledge embedded not just in his mind, but in the very muscles and reflexes trained through thousands of repetitions. And so the cycle continued, unbroken for centuries. Master training apprentice, who became journeyman, who became master, who trained new apprentices. Each generation preserved and slightly refined the ancient arts of the barber-surgeon, passing down a craft that, for all its limitations and misunderstandings, represented one of medieval society's most practical approaches to caring for the human body in both health and illness. As our barber-surgeon journeyman sets up his practice, tools laid out carefully on a worn leather cloth, customers coming to him for both grooming and medical care, he operates in a world of divided medicine. For while he plies his trade with hands made skilled through years of practical apprenticeship, across town another kind of healer moves through the chambers of the wealthy, dressed in fine robes, speaking Latin phrases, and turning up his nose at the very idea of manual medical work. This is the physician, and the tension between these two branches of medieval medicine tells us much about how society viewed the human body, knowledge, and the very nature of healing itself. The division between barber-surgeons and physicians cut deeper than simple professional rivalry. It reflected fundamental splits in medieval society, between practice and theory, between craft and science, between those who worked with their hands and those who worked with their minds. The physician embodied the scholarly tradition. Typically educated at universities like Salerno, Bologna, or Paris, he studied ancient texts by Galen, Hippocrates, and Avicenna. He could discourse at length about the movement of celestial bodies and their effects on human health. He understood the philosophical undersinnings of the four humours and could write elegant treatises on the proper balance of blood, phlegm, black bile, and yellow bile. What the physician did not do, however, was touch the patient, at least not in any significant way. Physical examination might extend to looking at the face, examining urine in a special flask held up to the light, or at most taking a pulse. Surgery, bloodletting, tooth extraction, these were considered manual labour, beneath the dignity of a learned man who had spent years studying Latin and Greek texts. Such tasks were left to the barber-surgeon, who was viewed as a craftsman rather than a scholar. This division wasn't merely about snobbery, though there was plenty of that. It reflected genuine philosophical differences about the nature of medicine. Physicians believed true healing came from understanding the entire body as a system influenced by diet, environment, and cosmic forces. They prescribed regimens of food, drink, rest, and sometimes medicines made of herbs, minerals, or animal parts. Their approach was holistic, theoretical, and often quite removed from the immediate problem at hand. Barber-surgeons, by contrast, dealt with the body in its most physical, immediate form. They saw blood, bone, and tissue. They felt swellings, lanced boils, and sewed wounds. Their approach was direct, practical, and focused on visible results. When a man came in with a rotten tooth causing unbearable pain, the barber-surgeon didn't lecture about the philosophical implications. He extracted the tooth, ending the suffering immediately. This contrast in approaches created natural territory for each practitioner. Physicians dominated in cases of internal medicine. Fevers, wasting diseases, digestive complaints, and other conditions with no obvious external cause. Barber-surgeons handled external problems, wounds, fractures, skin conditions, dental issues, and any situation requiring cutting or manipulation of the body. But territory once established rarely remains unchallenged for long. As the medieval period progressed into the Renaissance, the lines between these practices began to blur and tensions increased. Ambitious barber-surgeons, some having acquired basic literacy and even a few medical texts, began to treat internal conditions. They prescribed herbal remedies, suggested dietary changes, and occasionally ventured diagnoses for complex diseases, all traditionally the physician's domain. Physicians, for their part, became increasingly concerned about their income and status as barber-surgeons expanded their practice. They lobbied local authorities and guilds to restrict what barber-surgeons could legally do. In Paris, for instance, a series of edicts in the 14th and 15th centuries attempted to prevent barber-surgeons from administering internal medicines or treating serious diseases. Similar restrictions appeared across Europe, creating a patchwork of regulations that defined who could treat what conditions. For the patient, especially one of modest means, these professional battles created both confusion and opportunity. A craftsman suffering from persistent stomach pain might visit the local barber-surgeon first, knowing the fee would be affordable. If told the condition required a physician's care, he faced a difficult choice. Pay the much higher physician's fee or continue with the barber-surgeon's treatment, possibly in violation of local regulations. Many chose the more affordable option, creating a thriving grey market in medical care. Barber surgeons would treat patients behind closed doors, administering remedies they weren't technically authorised to provide. Some developed considerable expertise in areas officially reserved for physicians, learning through practical experience rather than formal study. The cost difference between these practitioners was substantial. A physician might charge several days' wages for a single consultation, making his services accessible only to the nobility, wealthy merchants, and high-ranking clergy. His visits were often ceremonial affairs, with the physician arriving in fine robes, perhaps accompanied by an assistant carrying his books and urine viewing flasks. He would speak in a mixture of vernacular language and Latin terms, deliberately mystifying his knowledge to maintain his elevated status. The barber-surgeon, meanwhile, charged more modest fees, often adjusting his rates based on the customer's ability to pay. A simple tooth extraction might cost a labourer half a day's wages, while a complex surgery would be more expensive but still within reach of the middle classes. This pricing structure meant that the vast majority of medieval people received their medical care from barber-surgeons rather than physicians, despite the latter's supposedly superior knowledge. The competition between these practitioners wasn't always hostile. In larger towns and cities, a kind of symbiotic relationship sometimes developed. Physicians would diagnose conditions and recommend treatments, then refer patients to specific barber-surgeons for procedures like bloodletting or minor surgeries. The physician received a referral fee, the barber-surgeon gained customers, and the patient benefited from both types of medical knowledge. This arrangement worked well enough in routine cases, but broke down during medical crises. When plague swept through a town, physicians often fled to the countryside along with the wealthy citizens they served. Barber-surgeons typically remained, treating victims as best they could, gaining practical knowledge about the disease through direct observation. When the physicians eventually returned, they might incorporate this hard-won practical knowledge into their theoretical understanding, rarely acknowledging its source. The true victim in this professional rivalry were the patients caught between competing medical paradigms. A man with a bladder stone might be told by the physician to drink special herbal teas and adjust his diet to dissolve the stone. A long, painful process with uncertain results. The same man might be told by the barber-surgeon that cutting was the only solution. A dangerous procedure with significant risks of infection or hemorrhage. Each practitioner truly believed his approach was correct, based on his training and understanding of the body. As the centuries passed, the strict division between these practices began to erode. By the late Renaissance, a new type of medical practitioner was emerging, the surgeon-physician who combined academic knowledge with practical skill. These individuals, trained in both traditions, began to bridge the ancient divide between theory and practice. They conducted anatomical research, developed new surgical techniques, and wrote detailed treatises combining philosophical principles with practical observations. The Barber-Surgeons Guild viewed these developments with mixed emotions. On one hand, the elevation of surgery to a more respected intellectual pursuit enhanced the status of all who performed surgical procedures. On the other hand, as surgery became more scientific and regulated, many traditional barber-surgeons found themselves increasingly marginalized, unable to meet the new standards of education and knowledge. The official separation came gradually across Europe. In France, a 1743 royal decree prohibited barbers from practicing surgery and surgeons from cutting hair, effectively splitting the ancient profession. In England, the Company of Barber-Surgeons was formally divided in 1745, with surgeons forming their own distinct college. Similar separations occurred across the continent, marking the end of a medical tradition that had served communities for centuries. Yet even as the formal profession divided, many practitioners, especially in rural areas and small towns, continued to offer both services well into the 19th century. The village barber, who could also pull teeth, lance boils, and set simple fractures, remained a fixture of community life long after the official division of the professions in major cities. The competition between barber-surgeons and physicians represents more than just a historical curiosity. It reveals how societies determine who holds medical knowledge, how that knowledge is validated, and who deserves the authority to heal. The physician with his books and theories and the barber-surgeon with his tools and practical skills were both attempting to address human suffering, approaching the same problems from radically different perspectives. Perhaps most remarkably, both traditions contained elements of genuine effectiveness alongside spectacular misconceptions. The physician correctly understood the importance of diet and rest in healing, while maintaining bizarre theories about cosmic influences on disease. The barber-surgeon developed remarkable skill in setting bones and suturing wounds, while accepting humoral theories that led to harmful bloodletting practices. Neither had a complete picture, yet between them, they carried medicine forward, each contributing essential pieces to our understanding of the human body and its care. As we've wandered through the smoky, blood-spattered world of medieval medicine, you may have noticed that our barber-surgeons have all been men, their bearded faces bent over patients, their male hands wielding razors and saws. Yet this picture, while common, is incomplete. For in the shadows of medieval medical history stood women who also cut, stitched, bled, and healed. Their stories have been partly erased, their contributions diminished, but make no mistake, women practiced as barber-to-surgeons throughout the medieval period, bringing their own perspectives and techniques to this ancient craft. The most common path for a woman to enter the profession was through marriage. A barber-surgeon's wife worked alongside her husband as a matter of course, learning the trade through daily observation and assistance. She mixed poultices, prepared instruments, held limbs during procedures, and comforted nervous patients. This informal apprenticeship meant that when her husband fell ill or died, she possessed the skills to continue the practice. These widow practitioners were found across Europe, maintaining shops that might otherwise have closed, serving communities that would otherwise have lost vital medical care. Court records and guild documents mention these women with surprising frequency. In 14th century London, a widow named Agnes Woodcock took over her husband's barber surgery practice and ran it successfully for years. In Paris, tax records show multiple women listed as barbières or surgeons, paying guild fees and operating legitimate businesses. In Frankfurt, a woman called Margrethe Kreutzerin inherited her husband's practice in 1423 and became known for her skill in treating eye conditions. These widows occupied a legally recognised position. Most guilds acknowledged that a master's widow could continue his business, employing journeymen to handle tasks requiring physical strength while she contributed her experience and client relationships. This practical arrangement benefited everyone. The widow maintained her livelihood, the journeyman gained employment, and the community retained access to medical services. But widowhood wasn't the only path for women into barber surgery. Some entered the profession as daughters rather than wives. A barber surgeon with no sons might train his daughter in the family trade, particularly if she showed aptitude for the work. These father-daughter practices existed throughout Europe, though they left fewer traces in historical records than husband-wife partnerships. The daughter would typically work under her father's name and guild membership, her individual contribution obscured but real nonetheless. More rarely, women entered the profession entirely on their own merits. In southern France and parts of Italy, a small number of women trained formally as surgeons, sometimes attending lectures alongside male students or receiving private instruction from established practitioners. These exceptional cases often involved women from families already connected to medicine, daughters of physicians or apothecaries who grew up surrounded by medical knowledge and materials. The most famous example is Jacoba Felici, who practiced medicine in early 14th century Paris. Though not specifically a barber surgeon, she practiced a broader form of medicine. Her case illustrates both the possibilities and limitations for women in medieval healthcare. Felici successfully treated patients that male physicians had failed to cure, developing a significant reputation. But in 1322, she was prosecuted by the medical faculty of the University of Paris for practicing without a license that, as a woman, she was not permitted to obtain. Her defense noted that she had successfully healed many sick people whom male physicians couldn't help, but the court found her guilty nonetheless, fining her and forbidding her to practice. This incident highlights the growing restrictions women faced as medicine became more regulated and institutionalized. In earlier medieval periods, when medical practice was less formally controlled, women's participation had been more widely accepted. But as guilds strengthened and universities established their authority over medical knowledge, barriers to female practitioners increased. Despite these obstacles, women continued to practice, particularly in specialized areas where their involvement was considered more appropriate. Female barber-surgeons often specialised in women's health issues, treating breast conditions, assisting with difficult births, and addressing gynecological problems that male practitioners might be prohibited from treating due to modesty concerns. They became experts in preparing ointments for skin conditions, a skill that straddled the line between medicine and cosmetics. Some developed reputations for their gentle touch in bloodletting, attracting patients who feared the heavier hands of male practitioners. Their techniques sometimes differed from those of their male counterparts. Women barber-surgeons were more likely to incorporate herbal knowledge into their practice, combining traditional women's plant lore with surgical techniques. They often emphasized pain management, using poultices of poppy, henbane or mandrake to dull sensation before painful procedures. Some historical accounts suggest they were more attentive to cleanliness, regularly changing bandages and washing wounds with wine or herbal infusions, practices that, though based on different theoretical understandings, may have reduced infection rates. These differences partly reflected women's broader domestic medical role in medieval society. Women were the primary healthcare providers within the household, treating family illnesses, dressing minor wounds, and assisting in childbirth. A woman who became a barber-surgeon was extending skills she had already developed in the domestic sphere, bringing this practical knowledge into the professional realm. Female barber-surgeons faced unique challenges their male counterparts didn't. They navigated complex expectations about appropriate feminine behavior while performing work that was often bloody, physically demanding, and associated with male authority. They charged lower fees for the same procedures, reflecting the lower value placed on women's work generally. They faced skepticism about their capabilities, particularly for more complex surgeries requiring physical strength. Yet they also had certain advantages. Female patients often preferred them for intimate procedures. Their lower fees attracted customers who couldn't afford male practitioners. And they could move between the worlds of professional medicine and traditional women's healing, combining approaches that male practitioners, anxious about their professional status, might reject as unscientific or feminine. The relationship between male and female barber-surgeons was complicated by both competition and cooperation. In some towns, male guild members viewed women practitioners as unwelcome competition, particularly widows who maintained independent practices beyond the expected mourning period. They passed regulations limiting women's participation or restricting the procedures they could perform. In Paris, for instance, a 1371 ordinance explicitly forbade women from practicing surgery, except under male supervision. Yet daily practice often differed from official regulations. Male barber-surgeons referred female patients to women practitioners for gynecological issues. They consulted women about herbal preparations and wound care. During outbreaks of plague or other epidemics, when all available practitioners were needed, these professional boundaries often dissolved in the face of overwhelming necessity. The historical record of women barber-surgeons becomes increasingly sparse after the 16th century, as the professions of barber and surgeon formally separated and surgical training became more institutionalized. Universities and new surgical colleges explicitly excluded women, closing off paths to legitimate practice that had previously existed through guild structures. Some women continued to practice in rural areas or poor urban neighborhoods, but they did so with less official recognition and greater vulnerability to accusations of illegal practice. The stories of these women, widows maintaining their husbands' practices, daughters trained by their fathers, independent practitioners developing their own techniques, remind us that medieval medicine was never exclusively male territory. In towns and villages across Europe, women's hands also wielded the barber-surgeon's tools. Their eyes assessed wounds, their fingers stitched flesh and set bones. Their contributions went largely unrecorded by a medical establishment increasingly dominated by university-educated men who wrote the histories and defined legitimate practice. But traces remain in court records, guild documents, patient testimonials, and the occasional illuminated manuscript showing a woman tending wounds or extracting teeth. These fragments suggest a richer, more diverse medical world than is often portrayed. Perhaps most significantly, these women barber-surgeons represented an important bridge between formal medicine and traditional women's healing practices. They carried herbal knowledge, birthing techniques and folk remedies into professional practice, preserving wisdom that might otherwise have been lost as the medicine became increasingly institutionalized. They treated patients who couldn't afford physicians or male barber-surgeons, extending medical care to women, the poor, and rural communities underserved by formal practitioners. So as our story of medieval barber-surgeons continues, remember that not all who wore the apron and wielded the razor were men. In shops across medieval Europe, women also stood behind the barber's chair, their skills honed through observation, necessity, and determination. Their stories may be harder to find, written in faded ink between the lines of official histories, but they were there, their presence as real as the blood on their aprons and the lives saved by their hands. While barber-surgeons handled everyday ailments and injuries in times of relative calm, it was during periods of widespread disease that their role in medieval society became most prominent and most perilous. When the cries of the town crier changed from announcing market days to counting the dead, when the smell of burning herbs and vinegar filled the streets in desperate attempts to purify the air, when healthy families in the morning became grieving survivors by nightfall, this was when the barber-surgeon faced the greatest test of skill, courage, and endurance. The most devastating of these epidemics was, of course, the Black Death. Beginning in 1347 and sweeping across Europe in waves for the next several centuries, this plague killed an estimated 1/3 to 1/2 of Europe's population. Streets emptied, villages were abandoned, mass graves filled faster than they could be dug. And in the midst of this apocalyptic scenario stood the barber-surgeon, often the only medical practitioner who remained when physicians fled to country estates with their wealthy patrons. Unlike university-trained physicians who could afford to escape, barber-surgeons were typically too embedded in their communities and too dependent on daily income to leave. Their shops became frontline hospitals during outbreaks. They were called to homes where entire families lay suffering. They walked streets where others feared to tread, carrying their leather bags of increasingly inadequate tools. For the barber-surgeon, plague wasn't an abstract medical concept to be debated in Latin. It was the swollen lymph nodes, the blackened skin, the blood-tinged sputum of neighbours and friends. To protect themselves while treating plague victims, some barber-surgeons developed primitive forms of protective gear. The most iconic was the plague doctor outfit, which became more elaborate over successive outbreaks. By the 17th century, this costume included a long waxed coat, gloves, and boots, but its most distinctive feature was the bird-like mask with a long beak. This beak was stuffed with herbs, spices, dried flowers, and sometimes vinegar-soaked sponges, all believed to purify the miasma or foul air thought to spread disease. While barber-surgeons rarely wore the full costume, which was more associated with specialised plague doctors, many adopted elements of it, particularly herb-filled pouches hung around the neck or masks covering the nose and mouth. They carried vinegar-soaked sponges to wash their hands between patients and burned juniper branches or rosemary in their shops to cleanse the air. None of these measures effectively prevented bacterial infection, but they represented the best understanding of the time and showed genuine attempts to limit contagion. The treatments barber-surgeons offered during plague outbreaks were based on the same humoral theory that guided their everyday practice, only applied with greater urgency and desperation. Believing that plague represented an extreme imbalance of humours, particularly an excess of black bile, they turned to aggressive bloodletting as a primary treatment. Veins were opened, cups applied, and leeches placed on already weakened patients, often hastening death rather than preventing it. For the buboes, the swollen, painful lymph nodes characteristic of bubonic plague, barber-surgeons applied a variety of poultices intended to draw out the poison. These might contain herbs like sage and rue mixed with animal fat, or more extreme ingredients like pigeon dung or crushed toads. When these failed, as they inevitably did, they might lance the buboes, releasing the infected pus in a procedure that was agonizing for the patient and dangerous for the practitioner. Other plague treatments in the barber-surgeon's arsenal included preparing theriac, a complex mixture containing dozens of ingredients that was believed to be an antidote to all poisons. They administered emetics to induce vomiting and purgatives to cause diarrhea, further dehydrating patients already suffering from fever. They prepared special plague waters for drinking containing herbs steeped in alcohol which at least had mild antiseptic properties even if they couldn't cure the disease. These treatments reflected the medical understanding of the time, but they also reveal something profound about the barber-surgeon's position during epidemics. Unlike physicians who could rely on theoretical explanations and distant diagnoses, barber-surgeons had to do something tangible. Their patients expected active treatment, not philosophical discussions about celestial influences or miasmatic theories. They were expected to cut, to bleed, to lance, to poultice, to intervene physically in a desperate attempt to save lives. The psychological burden of this role was enormous. Barber-surgeons watched patient after patient die despite their best efforts. They saw entire families disappear, sometimes including their own. They carried the knowledge that their treatments often increased suffering without improving survival. Yet they continued to work, day after day, in conditions of extreme risk and almost certain failure. Some found ways to adapt their practices based on observation. Though they didn't understand germ theory, experienced barber-surgeons noticed patterns in how plague spread. They observed that those who touched the sick or their belongings were more likely to fall ill themselves. Without understanding why, some began to implement what we would now recognize as basic infection controls, changing clothes after visiting plague houses, washing hands and tools with vinegar or wine, avoiding direct contact with bodily fluids when possible. These practical adaptations, born of direct observation rather than theoretical knowledge, occasionally improved survival rates, though never dramatically. More importantly, they represented an empirical approach to medicine that would eventually contribute to the development of more effective practices centuries later. The barber-surgeons' work during plague extended beyond treating the sick to handling the dead. When death rates overwhelmed normal funeral practices, barber-surgeons were often called upon to examine corpses, confirming death and identifying plague as the cause. Some assisted in preparing bodies, a task that carried extreme risk of infection. They advised families on how to dispose of a plague victim's belongings, usually recommending burning anything that had been in close contact with the deceased. Not all epidemics were plague, of course. Medieval Europe suffered regularly from outbreaks of smallpox, typhus, influenza, tuberculosis, and other infectious diseases. Each presented different challenges and called for different approaches. During smallpox outbreaks, barber-surgeons lanced the pustules and applied cooling ointments to ease the intense itching. For the sweating sickness that ravaged England in several waves, they prescribed rest and moderate warmth, avoiding the extreme heating treatments that often killed patients faster than the disease itself. The experience of repeated epidemics shaped the barber-surgeon's practice even in normal times. Those who survived major outbreaks carried valuable empirical knowledge about which approaches seemed to help and which made things worse. They became more cautious about bloodletting severely ill patients, having seen how it weakened those fighting infection. They developed greater respect for cleanliness, not because they understood bacteria, but because they had observed its practical benefits. This hard-won knowledge passed from master to apprentice, often in the form of specific cautions. Never bleed a patient with the spotted fever. Always wash your hands with vinegar after touching putrid wounds. Keep smallpox patients away from those with child. These rules of thumb, based on observation rather than theory, sometimes contain genuine medical wisdom buried within misunderstandings about disease causation. For communities ravaged by disease, the barber-surgeon who stayed to treat the sick often became a folk hero of sorts. Songs, stories, and local histories recorded the names of practitioners who remained at their posts while others fled. In some towns, barber-surgeons who survived plague outbreaks were granted special privileges or exemptions from certain taxes as recognition of their service. These rewards acknowledged not just their medical work, but their courage in facing almost certain death to help others. Not all barber-surgeons were heroic, of course. Some exploited epidemic fear to sell useless preventatives at inflated prices, special amulets, plague waters, or protective ointments that did nothing to prevent infection. Others abandoned particularly dangerous procedures, refusing to lance plague buboes or examine victims too closely, limiting themselves to safer services like preparing herbal remedies that could be left at a doorstep without direct contact. The relationship between epidemics and the barber-surgeon's profession was not only about treatment, but also about survival, professional as well as personal. Major outbreaks decimated the ranks of medical practitioners. In some towns, all the barber-surgeons died, creating shortages that led to relaxed guild requirements or opportunities for practitioners from other regions to establish themselves in new communities. These population shifts following epidemics sometimes brought new techniques or treatments as barber-surgeons moved between regions, carrying different traditions with them. A French barber-surgeon relocating to an English town after a plague outbreak might introduce different surgical approaches or herbal preparations, creating a cross-pollination of medical knowledge that might not have occurred otherwise. The plague years also accelerated the evolution of medical professions. As epidemics repeatedly demonstrated the inadequacy of existing medical knowledge, some barber-surgeons began to question traditional approaches and seek new methods. Others became increasingly specialized in epidemic disease, becoming de facto public health officials who advised town councils on quarantine measures, supervised isolation houses, and implemented basic sanitation improvements. Epidemics also affected the economic aspects of the barber-surgeon's practice. During outbreaks, normal grooming services declined as people avoided public places. Surgical procedures for non-emergency conditions were postponed. The barber-surgeon's income became almost entirely dependent on the treating plague victims, work that was both dangerous and often compensated poorly, as many patients died before paying or left families too destitute to settle accounts. Yet for all the hardship and danger, epidemics also revealed the essential nature of the barber-surgeon in medieval society. When theoretical medicine failed and learned physicians retreated, these practical healers remained, offering what comfort and care they could with the limited tools and knowledge available to them. They stood at the intersection of medical knowledge and human suffering, their hands bloodied, their remedies often futile, but their presence a testament to the human drive to heal and be healed even in the darkest of times. The legacy of these plague-time practitioners extends beyond their specific treatments, most of which were ineffective by modern standards. Their true contribution lay in maintaining medical practice during periods when it might otherwise have collapsed entirely, in documenting symptoms and outcomes that would inform later generations, and in demonstrating that direct observation of disease sometimes yielded more practical insights than distant theorizing. When the Black Death finally receded, and medieval towns slowly rebuilt their populations, the barber-surgeons who had weathered the storm found themselves with the new kind of authority, the authority of survivors who had faced the worst medicine could offer, and emerged with empirical wisdom that no amount of book learning could provide. This hard-earned knowledge would eventually contribute to the slow, halting transformation of medicine, from a theoretical discipline based on ancient texts to a practical science grounded in observation and results. As the medieval world gradually gave way to the Renaissance and then the Age of Enlightenment, the figure of the barber-surgeon, that curious hybrid of craftsman and healer, of groomer and cutter, began to fade from town squares and village streets. The red and white pole continued to spin outside shops across Europe, but the hands that once both trimmed beards and amputated limbs were increasingly specializing in one craft or the other. The decline of the barber-surgeon wasn't sudden like the fall of an empire or the burning of a library. It was slow, incremental, almost imperceptible to those living through it, a gradual separation of practices that had been intertwined for centuries. The forces driving this separation were numerous, complex, and interconnected. Perhaps the most significant was the advancement of anatomical knowledge. The medieval understanding of the human body had been largely theoretical, based on ancient Greek and Roman texts that had survived through Arabic translations. But in the 15th and 16th centuries, physicians and surgeons began to systematically dissect human cadavers, recording their observations with unprecedented accuracy. Andreas Vesalius published his revolutionary De Humani Corporis Fabrica in 1543, with detailed anatomical illustrations that corrected many long-standing errors. Suddenly, the internal landscape of the human body was being mapped with precision that earlier generations could never have imagined. This new anatomical knowledge demanded more specialized surgical training. The barber-surgeon's apprenticeship, while thorough in practical techniques, couldn't accommodate the expanding theoretical understanding of human anatomy. Surgery was becoming too complex, too scientific to remain joined with haircutting and shaving. The more ambitious surgeons began to distance themselves from their barbering origins, forming separate guilds and associations focused exclusively on surgical practice. In France, this process began in earnest with the establishment of the College of Saint-Côme, which set higher standards for surgical education and attempted to separate scholarly surgeons from barber-surgeons. In England, the Company of Barber-Surgeons, formed in 1540 under Henry VIII, maintained the traditional union of the two crafts for longer, but even there, tensions between the surgical and barbering components grew over time. The final legal separation came at different times across Europe. In France, a 1743 royal decree officially prohibited barbers from practicing surgery and surgeons from cutting hair. In England, the company of Barber-Surgeons split in 1745, with surgeons forming their own college of surgeons and leaving barbers to continue their grooming practice separately. Similar divisions occurred across other European countries, marking the official end of a dual profession that had served communities for centuries. For surgeons, this separation represented a step up in social and professional status. No longer associated with manual tradesmen, they could present themselves as learned practitioners, closer in standing to physicians than to barbers. They established formal schools, developed standardized examinations, and created professional societies that shared knowledge through journals and meetings. Surgery was transforming from a craft into a science, its practitioners exchanging the barber's apron for the surgeon's more dignified attire. For barbers, the separation meant a narrowing of their professional scope, but also a clarification of identity. They continued to perform minor medical procedures in many places. Tooth extractions, bloodletting and lancing boils remained within their purview well into the 19th century in some regions. But increasingly they focused on the grooming aspects of their tradition, developing new hairstyles, perfecting shaving techniques, and creating specialized products for hair and skin care. The common people, especially in rural areas, experienced this transition more slowly than the official decrees might suggest. Village barbers continued to pull teeth and lance boils long after such practices had been formally prohibited. In remote regions, the barber surgeon endured as the only accessible medical practitioner well into the modern era. The formal separation of professions mattered little to a farmer with an abscess who lived days away from the nearest qualified surgeon. Yet despite this gradual and uneven decline, the legacy of the barber surgeon lives on in numerous and sometimes surprising ways. Most visibly, the iconic barber pole continues to spin outside barbershops around the world. Its red and white stripes are direct reference to the bloodletting bandages that once hung outside the barber surgeon's establishment. Few modern hair clients recognize this bloody symbolism as they enter for a trim, yet they participate in a visual tradition stretching back hundreds of years. More substantively, the barber surgeon's practical, hands-on approach influenced the development of modern surgery, while university-trained physicians were still debating theoretical aspects of medicine. Barber surgeons were developing effective techniques for amputation, wound closure, and other practical procedures. Their empirical approach, learning through direct observation and experience rather than ancient texts, anticipated the scientific method that would eventually transform all of medicine. Some of their specific techniques survived the transition to modern surgery. The method of controlling bleeding during amputations by applying tourniquets and ligating blood vessels, refined by barber surgeons through centuries of battlefield experience, remained fundamental to surgical practice. Their development of specialized instruments, different shapes of forceps for various procedures, curved needles for suturing in difficult locations, various types of saws and knives created the basic toolkit that evolved into modern surgical instrumentation. The barber surgeon's approach to pain management also left its mark on medical development. Their use of alcohol, opium preparations, and herbal sedatives to dull the agony of surgery represented early attempts at anesthesia. While woefully inadequate by the modern standards, these efforts to mitigate suffering recognized the humanitarian aspect of medical care, a recognition that would eventually lead to the development of effective anesthetics in the 19th century. Even their mistakes and misconceptions sometimes contributed to medical progress. The practice of bloodletting, while based on incorrect humoral theory and often harmful, required barber surgeons to develop detailed knowledge of the body's vascular system. They learned which veins were accessible, how blood flowed, and how to control bleeding, knowledge that would later prove valuable when blood transfusion and circulatory research began in earnest. The barber surgeon's dual role also left a legacy in the structure of medical professions. The eventual split between surgeons and barbers mirrored other specializations in healthcare, the separation of apothecaries, now pharmacists, from physicians, the emergence of dentistry as distinct from general medicine, and the later development of nursing as a formal profession. This pattern of increasingly specialized medical roles, beginning with the barber-surgeon divide, characterizes modern healthcare. The community-centered practice of the barber-surgeon also influenced aspects of modern medical care. Unlike physicians who primarily served the elite, barber-surgeons treated people of all social classes, maintaining close connections with the communities where they worked. This tradition of accessible care eventually informed the development of general practice and family medicine, fields that emphasize ongoing relationships with patients and attention to community health needs. Museums across Europe now preserve the tools and techniques of barber-surgeons. In London, the Old Operating Theatre Museum displays surgical instruments dating back centuries. The Deutsches Medizin Historisches Museum in Ingolstadt, Germany, houses an extensive collection of barber-surgeon equipment. These artifacts, the bone saws, bleeding bowls, dental forceps, and trepanning drills, stand as tangible reminders of a medical tradition that helped bridge the gap between ancient practices and modern surgery. Academic interest in barber-surgeons has grown in recent decades, with medical historians recognizing their significance in the development of healthcare. Scholars study surviving guild records, examine preserved instruments, and analyze accounts of procedures to better understand how these practitioners influenced the evolution of medicine. This research has helped restore barber-surgeons to their rightful place in medical history, acknowledging their contributions after centuries of being somewhat marginalized in historical narratives that favored university-trained physicians. Perhaps the most profound legacy of the barber-surgeon lies in the concept of medical care itself, the idea that suffering can be alleviated through skilled human intervention. In an age when disease was often attributed to divine punishment or astrological influences, barber-surgeons offered a different perspective: that pain could be addressed, wounds could be closed, teeth could be extracted, and bodies could be helped to heal through practical knowledge and skilled hands. This perspective represented a fundamental shift from fatalistic acceptance of suffering toward active intervention. When a barber-surgeon removed a rotting tooth or drained an abscess, they demonstrated that human action could relieve pain, even if their theoretical understanding was limited. This principle that suffering can and should be addressed through skilled care remains central to all medical practice today. As modern surgeons perform microscopic procedures with robotic assistance, as lasers replace scalpels for certain operations, as computer simulations help plan complex surgeries, all of these advancements stand on the foundation laid by centuries of barber-surgeons who refined their craft through practical experience and passed their knowledge from master to apprentice across generations. The barber-surgeon has vanished from our streets, replaced by separate professions that divided their ancient duties. Yet something of their spirit persists, in the surgeon's commitment to hands-on intervention, in the barber's community-centered practice, and in the shared belief that skill and care can alleviate suffering. The red and white pole still turns, a silent reminder of a time when the hand that trimmed your beard might also have saved your life. And so we've travelled from the smoky, blood-spattered shop of the medieval barber-surgeon to the pristine operating theatres and stylish barbershops of the modern world. We've witnessed procedures that make us cringe and theories that make us wonder. We've seen hands that worked with remarkable skill despite limited knowledge, and minds that stretched to understand the body with the tools available to them. The story of the barber-surgeon is, in many ways, the story of medicine itself. Imperfect, evolving, sometimes harmful but always reaching toward healing. It reminds us that medical knowledge doesn't simply progress in a straight line, but develops through complex interactions of theory and practice, of tradition and innovation, of individual insight and collective wisdom. As you drift towards sleep, perhaps you'll appreciate that the next time you sit in a barber's chair or undergo a surgical procedure, you're experiencing the separated halves of an ancient profession that once stood at the very centre of community health and healing. The barber-surgeon has disappeared, but their legacy surrounds us still, embedded in the very structure of how we care for bodies and alleviate suffering in the modern world. As the barber pole continues its eternal spin, we come to the end of our journey through the blood-spattered, herb-scented world of the medieval barber-surgeon. We've walked alongside them through smoky shops and plague-ridden streets, observed their curious blend of grooming and medicine, winced at their surgical techniques, and witnessed their gradual transformation into the separated professions we know today. But before we part ways, let's pause to reflect on the strange paradox these practitioners represent in the long story of human healing. The barber-surgeon stands as one of history's most fascinating contradictions, a healer who sometimes harmed, a medical practitioner working without understanding the body's true mechanisms, a craftsman whose tools served both vanity and necessity. Their methods, viewed through modern eyes, often seem barbaric, even horrifying. The thought of having a tooth extracted without anesthesia, A limb amputated with only alcohol to dull the pain, or blood deliberately drained to treat a fever, makes us grateful for the centuries of medical advancement that separate us from their world. Yet there is something profoundly human about these practitioners that transcends their technical limitations. They represent the fundamental drive to help, to heal, to intervene against suffering, even with imperfect tools and incomplete knowledge. When they stood over a patient, razor or saw in hand, they embodied courage, both theirs in attempting such procedures and their patience in enduring them. Each bloodletting bowl, each dental key, each amputation knife tells a story not just of medical practice, but of human endurance in the face of pain that modern people can barely imagine. The barber-surgeon also reminds us that medicine has never been merely a science. Long before evidence-based practices and controlled studies, healing was an art, a craft, a relationship between practitioner and patient. The barber-surgeon knew their community intimately. They cut the hair of the same people whose wounds they stitched, shaved the beards of men whose teeth they later extracted. This personal connection, this embedding of medical care within the fabric of daily life, contained wisdom that modern medicine sometimes struggles to maintain despite all its technological advances. We can smile at the thought of having our hair cut in the same chair where someone's leg was amputated hours earlier. We can shake our heads at theories about cosmic influences on bodily humours, but we shouldn't mistake technical primitiveness for a lack of care or commitment. These practitioners did the best they could with what they had, their dedication evidenced by those who stayed to treat plague victims when others fled, by the careful design of their specialised tools, by the detailed guild regulations that attempted to maintain standards of practice. The history of barber-surgeons also offers a humbling reminder about the provisional nature of all medical knowledge. They were absolutely certain about theories we now know to be wrong. They believed wholeheartedly in treatments we now recognise as harmful. Their textbooks and training presented the four humours as unquestionable fact, just as our medical texts present current understandings that future generations may revise or reject. This doesn't mean we should doubt modern medicine, but rather that we should approach it with appropriate humility about the limits of current knowledge. Perhaps most significantly, the barber-surgeon story reveals the artificial nature of the boundaries we've constructed within medicine. The separation of surgery from medicine, of dentistry from general healthcare, of physical treatment from mental health. These divisions would have seemed strange to the barber-surgeon who approached the body as an integrated whole, albeit through an incorrect theoretical framework. As modern medicine increasingly recognises the importance of holistic approaches, there may be wisdom to recover from an era before hyper-specialisation fractured the healing arts. For those who practiced this dual craft, there was no philosophical distinction between improving appearance and addressing illness. The same hands that sculpted a fashionable beard also drained a festering wound. The same eyes that judged a proper hairline also assessed the colour of blood for humoral imbalances. This integration reminds us that well-being has always encompassed both health and appearance, both physical function and social presentation, a wholeness that the modern distinctions sometimes obscure. As we've seen throughout our journey, becoming a barber-surgeon required extraordinary commitment, years of apprenticeship, mastery of diverse skills, and the development of steady hands that could perform delicate tasks under pressure. These weren't casual practitioners but dedicated professionals who, despite their limited theoretical framework, often possessed remarkable practical knowledge passed down through generations of careful observation. Their empirical approach, learning through direct experience rather than solely from texts, anticipated aspects of the scientific method that would eventually transform medicine. The barber-surgeon also stands as a reminder of medicine's often forgotten accessibility. Unlike physicians who primarily served elites, barber-surgeons treated people across the social spectrum. Their shops were open to craftsmen, labourers, merchants, and occasionally nobility, places where different social classes encountered one another in the shared vulnerability of physical need. This democratic aspect of their practice, though born of necessity rather than ideology, represents an ideal that healthcare systems still strive to achieve. Even the decline of the barber-surgeon holds lessons about the evolution of expertise. The gradual separation of the surgical and grooming arts wasn't merely about professional status, but reflected genuine advances in knowledge that required greater specialisation. This pattern of generalists giving way to specialists as knowledge deepens continues to shape medicine today, bringing both benefits of expertise and challenges of fragmentation that require ongoing navigation. As our story comes to a close and your eyes grow heavy, Perhaps you'll dream of red and white poles spinning slowly in medieval streets, of shops filled with the mingled scents of soap and herbs, of practitioners whose hands moved with practiced precision between haircuts and surgeries. Perhaps you'll feel a distant connection to those who sought care in those shops, their hopes and fears not so different from our own despite the centuries between us. For in the end, the story of the barber-surgeon is our story. The human quest to understand our bodies, to ease each other's suffering, to face illness with the best tools available to us, however imperfect they may be. From the bloodletting bowl to the modern operating theatre, from the barber's razor to the surgical robot, this quest continues, evolving but unbroken, a thread connecting us to those medieval practitioners who did what they could with what they had, serving their communities with skilled hands and determined spirits. And in that unbroken thread of human care, perhaps there lies the truest legacy of the barber-surgeon, not in specific techniques or theories, but in the enduring commitment to place healing hands upon suffering bodies, to stand alongside the ill and injured, to face together what cannot be faced alone. It is a legacy written not just in medical textbooks, but in the fundamental human drive to help, to heal, and to hope. A legacy that continues wherever one human being works to ease the pain of another.